the service delivery, because the entity, everything is all about service delivery. If we don't get it right in service delivery, of course, we'll not be able to improve our nutrition in our various states. We also need to also begin to look at the stewardship system for sustainability. We must ensure that especially at the federal level and of course at all levels, we begin to look at how indeed we can sustain, this great and wonderful project in all of our states. And I'm sure the federal ministry, the national planning, agency, the national primary health care, they are ensuring the fact that, yes, indeed, they must begin to look at the issues of financing, for sustainability, looking at the issues of accountability around financing, and of course, looking at the issues of transparency, around financing. And in it all, the issue of coordination of the whole project on its own is also key. We must all begin to look at how, because we all talk about multi-sectoral, coordination, multi-sectoral project or program. How do we then begin to put in place the coordination system or mechanism, for the multi-sectoral system? I think these are issues, great issues that came up yesterday, and we must begin to look at how we, as a people, we must begin to look at how we can solve some of the challenges around these issues in order for us to be able to improve the nutritional status of our children, the mothers, lactating women, and of course, adolescents in our group. On that note, I welcome you all once again to this great meeting. Give yourself a round of applause for coming here early, which is wonderful. Next, we will be going through the feedback for day one. Can we have the feedback for day one? Who is responsible for that? A pharmacist.
I'm not yet your minister. Wonderful day. So we are here to just try and refresh our minds and memories on what really happened yesterday. So quickly, I would like to go to the recap of day one. No, the previous slides. Back. So the meeting actually started by 9:30 with the recitation of the second stanza of the national anthem by all. Then the meeting was moderated by the one and only Mrs. Gabriel. As we all know her, she has been in the nutrition space for a very long time, and she's one of the founding fathers of nutrition in Nigeria. So she urged all participants to maintain a 1-minute silence for the 2,300 under 5 children that die daily due to malnutrition. After which, she introduced the national program manager by name, Mrs. Sholanke. Next slide. So where the national program manager gave an overview of the ANRiN project, she discussed extensively on the project background, including the various DLIs ranging from 1 to 6, the institutional arrangement, as well as the 2 components of the project, namely basic package of nutrition services and stewardship and project management. Next. So then the next presentation was made by Dr. Ogechi Akalano, who is the the head of nutrition of the MPA CDA. And the title of the presentation is Service Delivery Through PHC Facilities, which happens to be under DLI 5. Next. Some of the highlights of our presentation include introducing the ANRiN DLIs, then the basic package of nutrition services under DLI 5, the roles of different actors, then of course the project achievements so far. So thereafter, we entertain questions, the responses we are given accordingly. Next. Then after her presentation, presentations were made by the following states: Kwara, Kogi, Gombe, Nasarawa, Oyo, Kano, Abia, and Niger states. After which questions were asked and responses were given by the various focal persons represented by these states. Next. Then afterwards, we had to welcome our main presenter who presented the theme of the conference, by name Professor Obinna Ojeku, who is the Director of Research, University of Nigeria. He made his presentation virtually on the conference theme, leveraging result-based approaches to improve nutrition service delivery. And he did justice to that theme. And he entertained various questions, and he answered accordingly. Then after that, we went to panel symposium, which was moderated by Dr. Binyerem Ukire, who is the Director of Nutrition, Federal Ministry of Health. And the topics of discussion are as follows. 1, performance-based financing for nutrition, the NSHIP/additional financing implementation, which was given by pharmacist Mohammed. And then we have the multisectoral nutrition and health project, Democratic Republic of Congo, by Dr. Ndei Kadi Toure, World Bank, DRC. Then, of course, we have the Maternal, Infant, and Young Child Nutrition Program by Marilyn Molomba International Medical Corps. Next. Then, of course, the opening ceremony that we have been awaiting since morning had to come in by the Honorable Minister. This was anchored by Mrs. Gabriel on the arrival of the Honorable Minister and his entourage. The opening remarks was given by the Permanent Secretary, who is ably represented by Dr. Ismail, where he welcomed all participants for this first annual conference, which is first of its kind in the country. Next. Then afterwards, the Honorable Minister gave his keynote address, where he informed participants of his total commitment to improving the nutritional status of all Nigerians. We all know that the federal government has been committed to saving lives of not only on the 5. Of course, we know our main focus is on the 5, but of course, we are now adopting a life cycle approach. We are not leaving anybody out from under 5 to adolescent to elderly, maternal. And of course, you know, we have been leaving men out, but this time around, we try to bring the men in so that we don't leave any person behind. So, and goodwill message was made by virtually by the Honorable Commissioner of Health from Nasarawa State, by name Pharmacist Ahmed Baba. He thanked the organizers for the opportunity and also promised the support of Nasarawa State government towards nutrition activity, and of course the ANRiN project, which is our center of attraction here. Next. Then after that, we entertain our vote of thanks from Dr. Salma Anaskolo, who is the Director of Family Health Department, where she thanked the Honorable Minister of Health, as well as the representative of the Permanent Secretary for finding out time to come and grace the occasion. She also appreciated all participants that are present, both physically and virtually, despite the COVID-19 pandemic. Next. Next. Then it was followed by a group breakout sessions. And the breakout session was the participants were grouped into three. One, performance-based financing for nutrition, the NSHIP / additional financing implementation. And this was moderated by Mr. Cletus Ame. Then we have multisectoral nutrition and health project, DRC. This is moderated by Dr. Nneka Ong, who is the Director, Community Health Services in MPH-CDA. Then the third one is Maternal Infant and Young Child Nutrition Program, the IMC. And this was moderated by Rekia Idris. Next. So afterwards, the day one came to an end at around 6 p.m. And we all dispersed and promised all to reconvene today, which of course we fulfill our promise. So we'll ride on from where we stopped today to yesterday. So let's keep the fire burning. Thank you.
Thank you so very much. Thank you. Haven't gone through the feedback of yesterday. Do you think anything was missing? I think he did a great job at that. Can we give him another round of applause, please? Thank you, Pharmacist Zubair. Indeed, we're getting there. After that, I will be calling on the LOC chair to give us the objectives of this meeting. We talked at length about it yesterday, but because there was no coordinated, it was coordinated, the opening ceremony. So it was left out because of the emergency approach, at the end of the day. So the LOC chair is here to give us the objectives and explain to us what it's all about. Thank you.
Thank you. Mrs. Roslyn, thank you for the wonderful work you have been doing. I want to use this opportunity once again can I have my slides, please? Once again, I want to use this opportunity to appreciate every one of us. It's been a good outing and also a learning experience for all of us. Ideally, the LOC should have made some introductory remarks yesterday that would have built up to all the activities that were done yesterday. And unfortunately, some of the activities that were supposed to have been done, carried out just like the MC has said, during the opening ceremony, were not well captured. And the Federal Ministry of Health and MPH-CDA are very poised to ensure that those key activities that are very dear to our hearts are carried out this morning. And all we want to do now is just to refresh our minds on the objectives of this conference, which we are already all aware of. It's been mentioned over and over, directly or indirectly, since yesterday. But we want to lay more emphasis so that we can all know it, or even digest it more, And at the end of the conference, we're able to ask ourselves, and you too that is evaluating us, be able to say that really this ANRiN conference achieved the set objectives. Can I have the first slide? So just to review once again, we just want to share experiences, lessons learned, and innovative evidence-based results from the implementation of the ANRiN project in Nigeria. You can agree with me that this has been happening since yesterday. A lot of us have been very well informed by all our resource persons who honored this invitation and have been with us. Can I have the next slide very fast? And again, the conference, which is an annual conference, and we hope that it will continue yearly, even as the minister has said, provides us a good platform to share national and international best practices for performance-based nutrition results. And from all the presentations of particularly Professor Obina yesterday, we have been exposed to various forms of results-based financing, and so many strategies that will help us to accelerate nutrition results for Nigerians. Next slide, please. And finally, to the last objective of this great conference is to share experiences on use of state or local government health information system for reporting. And I know this is one of the key areas we are going to be focusing on for today. We're going to be having a panel symposium that's going to be dwelling on data issues. And we believe that through the ANRiN project, we'll be able to get it right for nutrition, especially at the LGA and at the state level information system. Thank you, and God bless.
Very much, Ma. Thank you, LOC Chair. I think we now have a clearer picture of what this is all about. I'm sure all of this went through all our various presentations yesterday. Thank you very much once again. And on that note, we are now going to we're now going to have a quick one. We're going to invite the World Bank, Dr. Ritgard, to please come forward and give us your goodwill message for this meeting. Yes, ma'am. She's online. She's online. Can you have that? I think before she comes on board, we all want to particularly appreciate the World Bank because, well, without them, we won't have the opportunity of this great project, isn't it? Some might say, oh yes, we borrowed the money. A lot of times you go to places to go and lend money, and they end up not giving it to you. You go back home naked and very worried about your next level. But that they have graciously done this, and not just given the money just to the country, but they have also been involved in supporting the utilization of the money. how best the money can be utilized for the children, the women, the adolescents of this country. I think it's a great thing to do. And so we show our appreciation to them. We thank them for their support. We thank them for both their technical support and their financial support. Thank you so very much. Dr. Ridwan, in particular, I heard, is so passionate about this project. And she has had tireless days working on this project. Indeed, we want to appreciate you. We appreciate you indeed. We indeed, as a nation, as a country, we appreciate you. Thank you so very much. Can we have her on now, please? Is she on? Okay. Okay, let's give her a round of applause. She will come maybe later, come on later. Now we will call on another big, very huge masquerade also. The Executive Director, National Primary Healthcare Development Agency. They have also been in the forefront, in the foreline of this project. We want to have Dr. Onu, who is representing him. So please come forward and give us a goodwill from the agency. Thank you very much. Give her a round of applause.
Well, we are always innovative in Nigeria, so this is part of the innovation. And I think it's one for us to actually pass on this message, our goodwill, to our people. The Honorable Minister of Health, the PAMSEC Federal Ministry of Health, Director of Federal Ministry of Health, World Bank, all partners, directors of the agencies, all of us here, and honorable commissioners at the state persons. I want to say good morning. I say this on behalf of the Executive Director, Dr. Fezo Shuaibu. He was supposed to be here yesterday, but he asked that I represent him. So I would just say a few points, seeing that this is not part of today, I'm part of yesterday. Yesterday, when the Honorable Minister was speaking, he talked about the irreversible damage from chronic malnutrition in Nigeria. And this happens not only in Nigeria, but in other countries for the first 1,000 days, which is a period from conception to child's second birthday. He also discussed what this means to us and what we need to do as a proven intervention. The ANRiN project, as the objective has highlighted, will be looking at some of the main causes of chronic malnutrition in Nigeria, which includes inadequate access to healthcare, including all the services that have been discussed. We're also looking at insufficient and poor quality food knowledge and practices, as well as the other things that have been highlighted for us, the project from the World Bank, the ANRiN Assessing Nutrition Results in Nigeria, is looking at also inappropriate caring practices and poor environment for young children and for women during pregnancy. For our response as a country, looking at the national policy on food and nutrition and the multi-sectoral policy, which provides the framework to address these malnutrition challenges in Nigeria. The World Bank support through the ANRiN project. Sorry, I've been scrolling up there. We are looking at 12 states that are participating, looking at package of nutrition-related services in PACs, doing antenatal visits, and also providing, as I have said, iron and folic acid, intermittent presumptive therapy, and counseling of pregnant women, nutrition in pregnant adolescent girls and children. What have we done so far? Within the last 8 months, we have showcased it yesterday, that we've been able to address some of this from February to September. We had a basic package of nutrition services for 3 contacts of IFA. We have seen significant increase in nutrition services in ANRiN-supported PHC facilities, and this has been towards the tireless efforts of the state persons, our mothers and our children, and for us at the National Primary Healthcare Agency. With the support of our dynamic ED, we've been able to support the states through supportive supervision, through handholding, through the planning, as well as implementation and design. We are happy to see these results showcased in this conference. And that is why we work together with the Federal Ministry of Health as a collaborator, as a co-chair of the LOC also. I want to say congratulations to the states for your achievements that has shown that the states can take it on. And you've taken it on as a bold step. So I want to congratulate you once again and all of us who are participating in this conference. I cannot but appreciate the World Bank again for this support. Thank you so much. This, of course, I am saying on behalf of Executive Director, National Primary Healthcare Development Agency. Thank you.
That was a beautiful one. Thank you very much, Dr. Onu. Thank you. Give her another round of applause. It was so precise, so detailed and precise. Thank you, Ma. Thank you so much for that one. Now, can we again try to see if we can get Dr. Ritka of the World Bank? She's going to join us. Oh, great. Okay. She's on? Or she will come? Okay, great. That will be fine. So we can continue with the meeting. Now, next, again, we are going to have presentations by project implementing states. Remember, we had some rules on ground for yesterday, 5 minutes each by each of the states. And of course, as we told you, there is a committee on ground that is looking at your presentation. By the end of today, there will be an award for the best state, the best presenter. What you've been able to put together in your state and how you've been able to come up with your presentation and how you're able to defend what you have put forward. On that note, I call on Kaduna State to give us their presentation. Hear me do this. Oh, your time is up.
Good morning, everyone. This is Kaduna State. I'm Mrs. Ramatu Musa Haruna. I'm presenting for Kaduna State. Next slide. Yes. Okay, I should go. This is the outline of the activity. Next slide. This is traffic coverage for the 4 LGAs that the intervention is ongoing. We have 4 LGAs, Kaduna South, Kubau, Chikun, and Jaba. And under every LGA, we have 4 facilities that are involved in this intervention. Next slide. These are the project activities and the description. We have successfully, we printed 32 counseling cards for counselors. We procured 7,000 sachets of SP, 630 things. Things of folic acid and fasolate. And then we printed 3,500 counseling cards, counseling brochures for pregnant mothers. And we equally printed 32 reporting registers and 2 summary forms and record booklets for the 16 health facilities. We had an orientation for the 8 nutrition focal persons, 4 nutrition focal persons, 4 M&Es, 9 state primary health care officials, and then we equally had orientation for the health workers, 36 health workers. We picked 2 per facility, and 2 per facility for counselors also. They were equally oriented on the priority ANRiN interventions in Kaduna under ANRiN. And then we have 32 community mobilizers picked from each catchment area and working directly to the facilities that the intervention is going on. Next slide. Achievements. We had a target of 6,738 pregnant mothers to meet, but we were able to have 8,441 contacts, which shows that we have exceeded our target by 1,662 between April 23rd and August 31st, 2020. The pregnant women who consumed a minimum of 90 tablets of folic acid and fasolate, our target was 6,738, and we had 8,723, exceeding the target with 1,985. Pregnant women who received intermittent presumptive treatment for malaria, that is SP, our target was 6,738, and we covered 7,934. We equally exceeded the target with 1,106 between April to October 31st, 2020. This is the trend analysis of service delivery data for ANRiN facilities, according to graph. Next slide. This is comparative analysis of ANRiN versus non-ANRiN facilities. If we can see from our graph, in January we had MNCH week. That is why the graph shoot up. Then later it dropped down from April to May. That was the period of lockdown. And then after the lockdown again, it come up. And in July we were supposed to have MNCH week, but we could not do it. But we developed a new strategy by using house-to-house outreaches and then routine. Then coming down to September, we had issue with the NDHS2, which I think it was a national issue that time. Almost all the ANC attendance was not reflected in the NDHS2. The comparative analysis of ANRiN versus non-ANRiN. Pregnant women receive hematinics. It's just the same as that of the first slide that we just shown. And then the comparative analysis of ANRiN for IPT 1 to 3, ANRiN facilities versus non-ANRiN facilities. Next slide. Proportion of eligible pregnant women reached with services in the catchment area for each facility. These are indicators: pregnant women who receive MIYCN counseling, pregnant women who consume a minimum of 90 folic acid and fasolate, and pregnant women who received intermittent presumptive treatment for malaria. Our contacts were divided into 3. to get the total number of women that were attended to. And this is the number. Total catchment population for the eligible pregnant women, we have 15,300, and those reached, we have 2,848. Then for the hematinics, we have the same, and then for the IPT, we have 3,291, which give us a proportion of 19% and 21%. The proportion of eligible pregnant women reached with services. That is just the graph showing that one that I've just talked about. Next slide. Then comparison of proportion of eligible pregnant women reached with services. Coverage comparison between ANRiN and non-ANRiN facilities. If we look at this particular comparison, when the program came, we decided to pick our facilities from the facilities that are poor performing to see the impact that the ANRiN project is going to do on these facilities. And we are happy. There was a great impact because we compare the ANRiN facilities with the high client flow facilities from the same ward, same catchment area. And we could see that because of the intervention, the poor performing facilities that were picked for ANRiN intervention were quickly raised up, and we are competing, or some even past the high volume facilities that were within that catchment area. Next slide. This is the total proportion of eligible pregnant women reached with services, total of pregnant women ANC attendance, according to the facilities. This is their percentage coverage. Then proportion of eligible is the same with the hematinics here, percentage coverage from different facilities that are offering ANRiN services. Then proportion of pregnant women that receive IPT 3, 1 to 3. Next slide. Thank you. We are supposed to have our annexes, our trainings, pictures, food demonstration equipment. We're supposed to be in the slides that we sent. I don't know what happened.
Okay. Okay, thank you very much. That was why you said next slide. Okay, because she was sure there were some other things there. Okay, that's a good one. Thank you. Maybe before the end of today, if we get them, we'll just use them as, during the tea break as, our tea break video show. Thank you very much, Kaduna State, for that great presentation. I know that Kaduna State has a wonderful nutrition program in place. Am I correct? Is there any linkage between that program and this ANRiN program? Just a quick one. Is there any linkage between is it CADNAP or something? Oh, yes, there is a linkage. That's the essence. Thank you very much. Okay. We call on Plateau State to please come and give your presentation. A round of applause. And for our online viewers, we again appreciate your presence, your participation, And at the end of these presentations, we will be taking questions and, of course, responses. We hope that you are there to ask your questions. You can chat with us online and submit your questions. Thank you so very much for your participation. Now over to Plateau State. Thank you.
Thank you. Good morning, everyone. My name is Lydia Ishaku, the ANRiN focal person for Plateau State Primary Healthcare Board. I beg to stand on existing protocols. The presentation. Next slide, please. This is the presentation outline. Next slide. Here we have the geographic coverage. ANRiN is currently supporting the provision of nutrition-sensitive interventions to pregnant women attending antenatal clinic in 9 PHCs. We have 9 wards, 3 local governments across the 3 senatorial districts of Plateau State. And this table is showing the senatorial district, the local government where the PHCs are, the ward, and the names of the PHCs. Next slide, please. Project activities. Service delivery through public health centers for improved nutrition and health outcomes, DLI 5.2. Nutrition-sensitive antenatal care to pregnant women attending antenatal clinic. And these services include 1. Sorry, please, next slide. Sorry, please. The services include 1, provision of 30 IFA tablets per contact, times 3 contacts for pregnant women. 2, we have the provision of IPT for malaria during a contact, times 3 contacts for pregnant women. Then we have provision of MRYCN counseling during each contact, times 3 contacts for pregnant women. We also had orientation and training for 18 community mobilizers. That is 2 per facility, because we had 9 facilities. That makes it 18, to facilitate mobilization, to sensitize and to support pregnant women to access nutrition-sensitive antenatal services in supported facilities. And that was done in February 2020. We also had a state-level orientation/training for key officers in the state. And we also had another training all in February for our LG nutrition officers, the M&E officers, and then the facility health workers, and 3 per health facility. Then we also had a state monthly data review meetings to submit and to discuss performance. And that was done monthly, but at a point in between March, April, it was halted due to the COVID-19 pandemic. Though the facilities kept on sending their data to us, and after the ease of the lockdown, we resumed our monthly data review. Also, we had quarterly supportive supervision to provide hands-on training to review service delivery and to address project challenges during the implementation period. We also had procurement of drugs and commodities worth about 3.75 million. This was also done in January. And the drugs, the commodities like the counseling cards, the brochures, all were distributed to the 9 ANRiN facilities. We also had utensils for food demonstration. This was also procured in January 2020 at the cost of 653,400 naira for the ANRiN facilities. Food demonstration started in the facilities in February 2020 and was conducted weekly across the supported PSC to demonstrate the use of locally available foodstuff in providing essential food nutrients, thus reducing malnutrition. Next slide. Program accomplishments, DLI 5.2. We have 3 indicators: the number of contacts targeted, the milestone achieved through the DHIS2. First, we had pregnant women who received MIYCL counseling. We had a target of 6,738 contacts, and we achieved that target. In fact, we exceeded our target, but for the purpose of this presentation. And this target was achieved between February and June 2020. Then the second indicator is pregnant women who consumed a minimum of 90 iron folic tablets. We had the same target, and this target was achieved between February and June. Pregnant women who receive intermittent presumptive treatment for malaria, at least 3 doses, the same target, the same milestone achieved. This target was achieved between February and October. All these activities were carried out in the health facilities. If you notice here, you will see that it took a longer time, and this is because of IPT3 not captured on the DHIS2. Achievements, trend analysis. From this graph, we started implementation in February. We had a high figure there. Going to March down to April, the figures decreased right up to May. This is simply because of the COVID-19 lockdown. But if you notice, around June, it started appreciating right up to September. And then from October, it started declining again. This is because of the strike action that the local government had within that period. So this is for total ANC. Next slide. This is for total IFA, the same trend. A decrease during the lockdown period. Then it went up from June, July, and then down again because of the strike action. Next slide. The trend analysis for total IPT is almost the same thing. Next slide. This is for IPT2, almost the same trend. Achievement, comparative analysis between the ANRiN and the non-ANRiN facilities. The blue line is showing the ANRiN facilities, while the orange is showing the non-ANRiN facilities. And from this graph, you can see that for the ANRiN facilities, the figures are far higher than the non-ANRiN facilities. This goes to show that ANRiN is creating an impact. Next slide. This is for total IFA, the same thing. You can see the difference between the ANRiN and the non-ANRiN facilities. Next slide, please. This is for IPT2, almost the same trend. Proportion of eligible pregnant women reached with services. Here we have the total women who were provided with these services, MIYCN, IFA, IPT1 and 2. We have our target, and then the next column is giving us the total population of pregnant women provided with services in the same ward within the same period. And under that, we have the figures. So when we worked it out, we got the percentage contribution by ANRiN facilities. So for MIYCN, we have 65%, that is ANRiN contributing to MIYCN within the same ward and the same period. Likewise, for hematics, we have ANRiN contributing 72%. Then IPT1 and 2, we have ANRiN contributing 68%. Next slide, please. This slide is just showing us the same table I just explained, the graphical presentation. Next slide, please. These are some of our pictures during our food demonstration session. We can see the food that has been prepared. The women there have been, they watched the processes, and the food has been shared to them to have a taste. And honestly, at this point, I will want to say that this strategy of food demonstration in the facilities has really increased our turnout. That is women coming for ANC. They do come out a lot because when we hear their comments, they say that the food demonstration has really helped them. They learn a lot. And when they go back, whatever they learn, they put them into practice. And also, for some of the facilities that do ANC on a daily basis, you discover that whenever there is food demonstration session, a lot of women turn out for these services. And it has really helped. Next slide. Thank you very much.
Thank you so much for that captivating presentation. Honestly, I was glued to it. Not just the food, though, but the entire presentation. I want to thank you so very much. Thank you. And it's interesting to know that, you see, no matter what, nutrition is very key. I like the man who said that if you don't take your food enough, as medicine, you will start eating medicine as food. So I think that's a glorious one. The food demonstration is able to bring the pregnant women, to the facilities, and I think that that's a good one. I was able to, there's a striking thing you also mentioned, which I got in maybe one or two presentations. I think that was very, very key for me. Plateau State, you were having state monthly review, state monthly data review, which I think is very key. You highlighted that. You probably have it in all of your documents, but it was highlighted in her presentation. I think that really caught me. And she did not just state it. She said, it's been submitted. These data are being submitted for review. They review all data analysis, and then they discuss them. They discuss them in line with their performance. That is what data is meant for. Most of us just collect data and we dump them on the shelf. Data collection should be used to assess the status of any program and to help us in our decision-making processes. Thank you so very much. That was clearly stated in your presentation. On that note, honestly, why didn't you just leave the food thing there now so that we take a look at it for some? That was highly delicious. They presented the greens, the achar, being beautiful. Now, I have the pleasure to call up Aqua Ibom to make their presentation. Give Aqua Ibom
Good morning, everybody. My name is Odorabo Akpan, a focal person for ANRiN in Akwa Ibom State. Next slide. Okay, this is the outline. Next slide, please. Okay, this is the geo coverage of ANRiN facilities. We actually picked 9 LGS and 9 facilities from the 9 LGS. And the pictorial actually showed the communities that the LGS, that each facility actually covers. You have from the 9 facilities, the number of communities that access each of the facilities. Next slide, please. Okay, ANRiN, the background, project background. It starts with the objective. ANRiN project objective is to increase the utilization of quality cost-effective nutrition services for pregnant and lactating women in Akwa Ibom State. As part of the implementation, the ANRiN SPHTDA is to achieve the set objective through contacts with pregnant and lactating women during ANC attendance at the PHCs. In Akwa Ibom State, we actually kick-started the ANRiN services by May 2019. And due to some bottlenecks, it didn't run smoothly. But by January, we actually had the full implementation plan. We had between January and February, actually, that's 2020, we had the training of the health staff from the state and the local government level. And that was between January to February 2020. And during that time, after then, we had the COVID-19 nationwide lockdown, which lasted till we had to do the implementation proper in August 2020. Project activities. We have provision of nutrition-sensitive ANC interventions to pregnant women across the 3 senatorial districts of the state. That's actually how we picked the 9 fertilities from. We actually selected them from the 3 senatorial districts to make it even. Number 2, we have the capacity building of healthcare workers and recruited community mobilizers. Provision of MIYCN counseling sessions, 30 IFA, and 1 dose of IPTP was given to pregnant women during each visit to the health facility. Mobilization of pregnant women to complete at least 3 facility contacts during the period of pregnancy. Please, I want to stress on that point because in Akwa Ibom we have this issue of how do you call them? The local women that actually indulge in services. Yes, they actually pose a big threat to us because at some point the women will be confused. What do? Do they get to the facility or do they continue with the TBS? So I think it's the community mobilizers from the meeting, they're actually stressed on that these women really need a lot of follow-up because some of them after the first intervention, they would rather derail to go back to them. So I think the community mobilizers are really doing a whole lot by trying to make sure that these women that come out to the facility, they still stick and complete their 3 visits. We have the monthly data meeting at the state level to analyze the data and share experiences and ideas. Quarterly supportive supervisory visits to supported health facilities. The next slide is achievements. The first one is we trained 40 states and local government officers, 24 community mobilizers, and 24 counselors. We also had the procurement and distribution of 360,000 doses of IFAS and 21,000 doses of SP. We conducted 5 monthly data review meetings. Why we were actually 5 is because we missed out in one of the meetings because of the primary healthcare development agency was under attack, and we lost everything. It was actually burnt down. So that's why we missed one of the meetings. And we had 2 quarterly supportive visits. Then on the last box, we have the our target for each of the interventions. For MIYCN, we actually exceeded the target. We had 9,412 for MIYCN, 9,604 for IFA, 7,232 for IPTP 1 to 3. Next slide, please. Trend analysis of service delivery data for ANRiN facilities. Okay, this is a pictorial of what actually happened in the ANRiN facilities before the onset, before we actually commenced ANRiN activities in the facilities. The purple box showed that from December 2019 to July 2020, that was the stand of these facilities. before ANRiN actually kickstarted in August. If you see the trend, from August, it actually went up. It had a rise in the assessment of the interventions. And by November, it started sloping. That was due to the fact that some health workers had issues. I think one is strike during that time. And from the January data, you will see that it actually rises, but it's not reflected here actually. Next slide. Comparative analysis of ANRiN versus non-ANRiN facilities. This is from August 2020 to January 2021. Then we have this comparison for the antenatal total attendance. We have the ANRiN facilities on the blue, or the blue shade. Then we have the non-ANRiN on the red shade. If you really check it out, you see a marked difference between the achievement in ANRiN facilities and that of the non-ANRiN facilities that cuts across the antenatal, the pregnant women who received IPT, the total women who received IFA. You can see the marked difference there, which shows that ANRiN is really working in these facilities. Next slide, please. Okay, comparative trend analysis of ANRiN versus non-ANRiN facilities. This is for MIYCN. As we have stated below, the red color shows that of non-ANRiN and the blue that of ANRiN. So you can see the trend, how it went. Then from when we had the inception of ANRiN interventions, from August, we had an increase in the trend. It went up to October. Then from November, we had the slope. That was due to the strike. And this actually cuts across all the interventions. Please, next slide. This actually cuts across all the interventions. We also have the same pattern for IFA. The same thing from August, it went up to October, then now came down in the other ones. Next slide. The same thing with IPTP 1 to 3. Thank you.
Thank you very much, Akwa Ibom. Another round of applause for Akwa Ibom. Thank you very, very much. I love the outlook of your presentation. Very, very well done. Very well done. Thank you. And on that note, we want to again appreciate our esteemed online participants for their great participation in this conference. Quite a number of them. I think we now have over 60 participants. I know the great day, the first day is always a great day where you have we had, at a point in time yesterday, we had over 200, 250 people online. I think that was great. For today, because it's still early anyway, we have over 60, 80 participants online now. A round of applause for our online viewers. They have been wonderful. Thank you. We appreciate you indeed. Now, you will also join in the questions and questions. You can send it. Oh, questions are beginning to come in from online. Great. We're now going to we're going into the questions and of course responses time. We have barely 10 minutes to do that. We'll be fast about it. 20 minutes to do that. Okay. Our first question is this from Olubumi Brahim. I want to find out if ANRiN project is comparison intervention or project that is meant to support and complement interventions that we have been implementing in our various states. Why? I think that's a very good question. It's key to all, very great question. Can I read it once again? So all the states, you must say something about this, please. Every state here present. Now, she's asking, Olubumi Ibrahim is asking, I want to find out
If ANRiN project is comparison intervention or project that is meant to support and complement interventions that we have been implementing in our various states. Why must there be gaps in services? Can't the state government bridge the gap, especially in a state like Kaduna? You know, I particularly said this because of the ongoing program in Kaduna. And Kaduna has a very, very viable nutrition platform. You know, so I think her question is very key and is in tune. Now, yes, please.
Okay. Good morning, all. Um, Actually, I want to respond to one of the questions that the viewers at the online asked. We at the Kaduna State, we don't know that. Actually, we can't say we don't know because we look at the higher and highest performance facilities. We categorize them into three. The highest one, they are the tertiary hospitals, while the middle one, they are the primary health cares. So when you check the data that was presented, the highest one, they are almost within the town. So there is no reason why if you are comparing your performance, you go for a low facility or low coverage. So we picked the one that have the highest performance. Then we randomly selected according to the list we categorized. So that is why the gap is not even, if it's not that much, because we looked for the highest performance facility. Thank you very much.
Good morning once again. ANRiN intervention is not a comparison intervention. Why we had to compare is just to see the impact of the ANRiN intervention in our various facilities. Just as I presented before, we picked the low performing facilities and then compare with the higher performing facilities to see the impact of this intervention in our various facilities. And for nutrition activities in Kaduna State, definitely we have so many partners that are supporting us in nutrition interventions. And so when you look at it closely, the gaps in our own graph is not much because of other interventions that are currently ongoing in Kaduna. Thank you.
Good morning, everybody. The question on the aspect that he talked about comparison, I think for any project that you are implementing, to know if you are progressing or not, you need to compare. What I would have thought that he would have asked would have been the method of comparison. Maybe, or because to my thinking, when you're comparing facilities, I think you should compare facilities with equal strength, equal client load, and give us baseline of both. That will give us a clearer picture. So I would like to say that maybe in future, the method of comparison should be uniform in all the states. It will give us a clearer picture.
Well, the chairman LOC wants to respond to that.
Okay, thank you very much, Ma. Mine is actually will I call it a question or a concern or a comment? I observed particularly from Plateau State presentation, even though it seems to have cut across all the presentations right from yesterday. But from the Plateau State on this one, the disparity, the difference, the gap between all the facilities and the ANRiN facility was so wide. So I began to ask myself, why is this so wide? Does it mean this state is not doing anything at all? Were they really at zero level? The graph in Plateau was so significant, almost a straight line. Or is it that we don't really have data? We know that we have paucity of data in Nigeria. Is it possible that in Plateau State, perhaps you don't even have baseline data on all those facilities? That's why it's almost like a flat curve. Or how did you really arrive at the data you used in plotting those graphs? And this rider, and I agree very much with the last speaker, that we have to use the same format across board, for comparison, and it should be based on what was the baseline when ANRiN implementation started. And now, where are we now? That should be the comparison per each facility, per facility. That's just what I want to say. Thank you.
Thank you very much. I think Plateau State said something during their presentation. I think they talked about the lockdown and some series of strikes and everything, because I think I listened attentively to that. But then I still also believe that it doesn't leave room for that flat, presentation. Okay. Any other response? So I saw you nodding your head.
From mapping, you can do all those elements, baseline. These are the things I thought the state will have done first to get the baseline. Usually you have to map. And I saw that they were saying the facility were selected. So in mapping, all those data elements should have been, what are the baseline? These are the things they should have first.
Yes, please.
Good morning, everyone. I just want to state in more clarification on the aspect of the question that was asked online. Going by the name of this project, Accelerating Nutrition Results in Nigeria project. This simply means that already the government or the National Primary Health Care in collaboration with Federal Ministry of Health already knows that there is an ongoing nutrition interventions in our various states. So this project is just here to accelerate it. It's not to compare. The reason why we compare is just for us to know our efforts and our achievements. I'm still talking about the online question that came up, whether ANRiN project is a comparison intervention or a supportive intervention. So ANRiN is just here to supplement, to complement what is already on ground, to accelerate nutrition activities. That is what it's all about. Thank you.
Thank you very much. I just want to add to what she said. If we don't compare between the ANRiN facility and non-ANRiN facility, there is no way we will know whether there is performance or not. The easy way to know the performance level is for us to compare. This is the facility that is having ANRiN intervention and one that is not having intervention. So in essence, it's not a comparison intervention. It's just for us to be clear on, or to have the impact, to know the impact of that intervention in those facilities. Thank you.
Any other question from our online viewers? Okay, we have one here. Thank you.
Yes, I just want to add my voice to one or two things, especially regarding still the last online question. That one good thing I think the ANRiN project has been able to achieve is that many times before now, we've seen that there are some areas that are well supported, partners will support. But I think the ANRiN project has made it clear in that from beginning they say they are supporting ANC sensitive nutrition interventions, which is good because that aspect has, prior to this time, not, I won't say neglected, but it's not as pronounced as we're supposed to have. So it's a good thing that we have partners looking at nutrition in various aspects because under 5 nutrition is highly supported. So this is one of the few times that we had a project that will go out and say, okay, this ANC sensitive nutrition, that's one. So it's really complementing the nutrition situation in many of the states. Then as regards the gaps, I think it's good that this project has brought out one particular thing, and it talks about data for maternal nutrition. Even before now, DHIS does not capture most of nutrition interventions, and the ANRiN project has helped to bring out, giving us a voice in terms of data. And that's why we are seeing that when we say gap between the those ones that are supported by ANRiN, and it's because we are collecting data regularly. We know that this is what we're looking for, as opposed to the data they will be collecting. And that's why you can see the difference a bit in most of the states. The non-ANRiN look as if it's flat. It's not that they are not collecting data, but many times they are not focused on the particular data. And that's why the ones in the ANRiN states seem to be, yes, they collect data for nutrition, but the ANRiN project has made us realize that we need to be focused on what we want and the interventions that we are targeted at so that it can bring out and speak for us, and we'll be able to use it to project. Because even using the HIS, we're not able to calculate maternal mortality rates, the rates, because we don't have the data we are looking for that will give us those kind of calculations. Thank you.
Honestly, before we round up for this session, we also need to begin to look at, can't this the other part of the question, and that is, can't the state government bridge the gap, especially in a state like, I think we need to start thinking about how our various state governments can bridge the gap. Okay? I think we have talked at length.
Thank you very much for that particular question. In our group that we had yesterday, we talked about that in group 1, the state government to come in so that the gap can be bridged by advocacy to our various states, to the government of the states, so they can buy in to this particular project. We still have a lot of states that we have minority children there, which nothing is done about them. So I know when we get back, even our viewers too, to our various states, we can usually make an advocacy visit to our decision maker in our states so that they can buy into this project, so that other states can equally join this particular project. Thank you.
Hello, ma'am. I want to talk about bridging the gap from our states. For Kaduna State, we have a budget line across all the 23 LGA for nutrition. Okay, so, okay. For Kaduna State, we have a budget line on nutrition across the 23 LGAs. And in the annexes that were omitted in my presentation, that could have enabled us to see the impact of the state. From the food demonstration commodities that we bought. We use the ANRiN fund to buy, then the state government complements with other commodities like grinding machine for the facilities, so that they will just use those grinding machines to grind whatever they need for their food demonstration. They don't need to go outside the facility or to contaminate other food items with other food from outside. So Kaduna State has been supportive in nutrition intervention. Thank you.
Thank you very much. I think that's, we've done a lot of justice to that question. At this point in time, I want to, well, it's tea break. But before tea break, there are some shifts from the norm. We were going to have leveraging nutrition sensitive and specific approaches, after tea break. But because Dr. Anthony Adoge had to leave for an urgent assignment, we are bringing him forward. You see, he's after lunch. We are bringing Dr. Anthony Adoge forward to come and give his presentation before Dr. Sylvester Igbedio. Dr. Sylvester Igbedio, I want to honestly apologize to you, sincerely apologize to you for this major shift. We're indeed sorry. It's just that he had some other assignments, from the main people. We thank you for your understanding. Thank you so much. And on this note, I want to call on all the LOC members for a group photograph here before they go for tea break. All others can go for tea break, but it is time for the LOC to come together for a group photograph. Sorry, a group photograph. So it's tea break times, just 25 minutes. We are behind schedule and we want to leave early today. Don't you agree? Today is the last day. We think we should leave early. It's not ready. Oh, tea break is not ready. Okay. Dr. Anthony. Okay, sorry about that. Sorry about that. Sorry for the shortfall. We'll now call on Dr. Anthony Adoge. Hey, don't disturb okay, okay. Sorry, I apologize to the house. Can the LOC just quickly take the photograph? Because there are other assignments for some of them. Ma? Hello. Now, can we have Dr. Anthony Adoge to give his, oh, you're here with us. Oh, great. It's not a
Yes, thank you. Now, protect the staff. So are they going to project the, okay. Good morning, everyone. And thank you for having me here at this conference. My apologies that I have to move my presentation to earlier than it was slated for. I actually lost my dad on Monday morning, but I felt it would be nice to do justice to this presentation before going to attend to those family matters. So thank you for having me. I'm here on behalf of the head of department, Health Research Planning and Statistics, to make presentations on strategies that the ministry and the entire health sector have taken to ensure that we use quality data for service delivery to make informed decision in health service delivery. It's going to be a very brief but interactive presentation, and if time allows, we will have some demo. So if we can have the presentation projected, please. Okay, thank you very much. So as a way of outline, I will introduce the topic, and then we'll look at the importance of quality data in health service delivery, and then look at the measurement of performance of health service delivery, what's the importance of doing that, and then look at the key strategies that the entire health sector, all of us have been able to undertake, and we are still working on in ensuring that we have valid data for decision making. And then we will do a bit of demo and close this with questions and answers. So we say, if we must have not just health service delivery, but if we must give quality health service delivery to our people, to all Nigerians, then we should ensure that we have quality data to help us plan. So right from the community level, our health facilities, whether it's primary, secondary, or tertiary, specialized service centers, we must ensure that all we do is backed by quality data. And in doing so, there's need to periodically assess what we are doing, our performance. Whether, like I said, you are involved in health service delivery or you are one of those planning health service delivery. We must once in a while use evidence as given to us by the data that we collect to drive the planning and programming processes. The WHO says that accurate, timely, and accessible healthcare data plays a vital role in planning, development, and maintenance of healthcare services. Quality improvement and the timely dissemination of quality data are essential if health service or health authorities wish to maintain healthcare at optimal level. So it's not just enough to collect quality data. You must share that data so that all those involved, all the stakeholders are able to make informed decisions. And if that is done, that is one of the ways through which we can ensure that we have optimal service delivery to our people. Now, let's look at the importance of quality data. I keep emphasizing the word quality. For those who are actively involved in performance-based financing approach, you will know that we have moved from just rendering services. The emphasis has moved from service delivery to quality service delivery. So whether it's the Basic Healthcare Provision Fund, whether it's the ANRiN project or program, what we now emphasize is how do we give quality services, health services to our people? Let's look at the community level. Permit me to say that we actually need more health service delivery at the so-called community level. Our data is beginning to show that more women give birth at home. We have more babies being born at home. Most of the services that are required are actually at the community level. The pilot that we have shown has done, has shown that the MPACD has moved swiftly to put in place the initiative called CHIPS. So they are helping to influence service delivery, basic service delivery at the community level to ensure that our people get quality care even before they move to the facility, before they are referred to the facility. So at the community level, we need to be able to provide meaningful statistics. How many people have headache? How many children are wasted? How many children are coming down with diarrheal disease? That's where you actually catch those conditions. How many are coming down with skin conditions? And it's when we do that, we collect quality data from the community level that we're able to quickly take informed decisions. So like I said, the CHIPS, we have developed what we call the Community Health Information System, which ties with the patient level data that MPACDA will be collecting through the CHIPS. And that is shared with the community leaders. For example, if you have cholera, you don't need to wait till 5, 10 children die. If children are wasting, you don't have to wait until they become extremely malnourished. When you share this data with the appropriate stakeholders on time at the community level, then they are able to make informed decisions, and there's also data ownership. So the community leaders will sit down and say, what do? We think there's a problem that's coming up. Our children are not eating well. They're not getting the right quality of food. What do? Do we report to the State Primary Healthcare Board? Who do we report to? Is it the ANRiN program? Who do we talk to? That's because they can see their data. Now, at the service delivery points, which we all know very well, primary health centers, secondary health centers, the tertiary health centers, and the specialized centers. A lot of information. We need to be able to gather meaningful data at those levels to be able to ensure that we give patients quality care. Let's focus on nutrition, for example. Immediately, most children under 5 walk into our facilities. They are quickly weighed. Their vital signs are taken. Whether it's the temperature, the heart rate, the respiratory rate. But one challenge we have seen at the service delivery level in our facilities is that those children that they weigh, almost all our registers are blank. So the nurses, the CHUs, the JCHUs see the need to weigh the children under 5, our infants, but they never record in the appropriate register. That's a problem for us. And so when you're looking for children that are underweight, when you're looking for the data on the DHIS2, it's not there, and it's supposed to be there. It's a very, very important nutrition indicator that's needed for programming. So, as highlighted, there are a lot of things that we can use quality data for at the service delivery point. A lot. The next I want to talk about is at the agency, whether you are NHIS, whether you are MPACDA, whether you are NAFDAC, whatever health agency you are at the federal, state, and even local government level. And then the Ministry of Health at the state and the federal level. What do? We make policies, we review policies, we coordinate things, whether it's in regards to nutrition and all that. We need data to be able to plan. We need data for the coordination of care. So as you are collecting data at the facility and community level and you are sharing, I use the word sharing because for those at the service delivery point, they keep saying, we are reporting to the agencies, to the State Primary Healthcare Board, to the Federal Ministry of Health, to the State Ministry of Health. No, you are not reporting. You are sharing information with us to be able to plan for you, help you plan, or plan with you rather. So at the agency level, at the Ministry of Health, like I said, we need data to be able to plan. You cannot have COVID ravaging your country, and then you say, all we will do is focus on COVID and leave essential services alone. From the data we saw during last year, during the lockdown, antenatal services and delivery were untouched. Women still went to the facilities, even during the lockdown. The data showed us that, which means those services needed to continue. Data is showing us now that we have more deliveries. At the agency and MOH level, we need to be able to say, oh, we still need to ensure that we have all the commodities needed by pregnant women, by children under 5, because regardless of what is going on, they will still go to access service. It's data that will show us that. For our research and partners, oftentimes we think for the partners, well, sometimes they are taken care of. If you don't give them the data, they go and commission people and get the data themselves. But the challenge with that is when you go report the data, we come as a country and say, that is not our data. But there's no need to have all those kind of fights. So we say, let's work together, strengthen the system, because you need the data to plan. You need the data to be able to send your money to where the development issues need to happen. For researchers, we rely heavily on them. Even though we collect data and they come in, we need researchers to say, maybe this is not where to focus on. Maybe we need to move away from the traditional approach and focus more on on the PBF approach. Maybe there is even a hybrid way of doing things. So it is data that will provide all that information for us. Now, let's talk about the characteristics of this quality data we keep talking about. Now that we've understood the importance of data, or some of the importance of data, we say data must be accurate and valid. When I looked at the topic when it was sent to me, I said, okay, I understand that we are not just talking about valid. Once we train the word validity, it means the whole thing. So when we say data must be accurate and valid, it means that it must come to you who needs to make a decision, whether you're at the facility level, community level, agency, MOH level, or whether it's at the global level. It must come to you in its original source. I cannot say I am male, and before the information travels to the end of the room or outside this room, they say, oh, there's one lady that's making presentation there. It means it's not the same thing. So when you begin to share data from the source, we need you make decision with accurate and valid data, but also as you share with us, you also ensure that it is the same thing that's on your register that comes to decision makers. The data must be reliable. What does that mean? It means that it must be consistent. Today you send one thing, tomorrow you send another thing. We're not sure if we can rely on that data because it's not consistent. If I go and check the source register and check the other one, say, no. What is shared with A is not the same thing that is shared with B. It's not consistent. We can't make decisions with such data. And then it must be complete. On the DHIS2, we say, is the data complete? Are you reporting all the data elements, all the data sets? So if there are 20 tables here, and you want to serve lunch or tea break, and then you count only 7 and give to the hotel, by the time they schedule 7, others will be aggrieved because you have given them incomplete information, and that's how it can cause problem. You want to undertake nutrition services in a state. You have projected, you have done your calculation, and you say, well, this year we think that about 200 children will be needing nutrition intervention services. Meanwhile, there are actually 4,000 children. You have done a lot of disservice to those other children. And then you say, okay, you can wait for next year. The data must be legible. Of course, we must be able to read. When we go to the facility and we see that what you have written in your register is not legible, we just cross it out and say, we don't understand what you're writing. The data must be current and timely. I wish to speak to some of the things we have done about the issue of timely and current data. There's no point you are carrying out an intervention, and then usually what we'll see is, oh, they've not audited the information, that's why we have not sent it. My commissioner has not approved. The state person has not approved. And then eventually when the data comes, it's only for reference purpose. We can't use it to plan anymore. So what we have done is about 10,000 facilities in the country now report with mobile phones directly into the DHIS2. And with the Next Global Fund support, we are hoping that we can reach out to more facilities. And then we are also going to integrate all the electronic medical records in all our tertiary facilities into the DHIS2, integrate it with the DHIS2. Now, for the community level, for the pilots that we did, we gave mobile phones to the volunteers. And we said, after 2 years, you can own the phone. We're exploring all that. And when we said that, no phone got missing. There are other phones that we said, if you want to enter data, go to the facility and use the phone. The phone is sitting in the facility there so that the in charge can supervise when you are entering data. That way, we ensure that data comes in in a timely manner. It doesn't have to delay. You carry paper from community to community. Before we see you, it's at the end of the month. When we need to take action, because we can see that there's an ongoing cholera outbreak, or we think there's an outbreak we don't understand, we can quickly mobilize and take action. Now, accessibility. If I don't have access to information, in M&E, we say what is not measured. When we say what is not measured, if you like, you measure it yourself. If the people who are supposed to take action on that particular issue cannot see, they cannot access that data, we say you are not doing anything, because it means that you are on your own. So your data must be available, must be accessible, and the innovative ways of doing this, like I will mention later, is through dashboards. Dashboards at all levels. We should be able to create dashboards, make your data accessible, let the whole world see. The time where we used to hide information from each other has passed. Everything must be visible to everybody, whether at the facility level, at the agency level, ministry level, even the donor and development partner level. Now, issue of confidentiality and security. Because, for example, at the federal level, we deal with aggregate data. So you tell us how many people came to your facility, 7, 10, 20. But at the facility level, at the program level, you deal with patient level data. It is a crime anywhere in the world. According to the National Health Act, it is a crime to expose patient level data, where my name is, your name is, the name of any child recorded down. It is a crime to expose that data without appropriate laws and regulations being followed. So quality data must be confidential and secure at all times. So next slide, please. Now we want to, are we all together? Okay. Now we want to go to, yes, WHO says again, emphasizes the importance of quality data. But now let's go into strategies that we have undertaken to ensure data validity. I've listed them here to say some of the very key strategies is that we must, and we have as a country, focused on governance, data governance, and data policies. The health information system platforms, we have also taken measures to ensure that they are integrated and continue to be integrated, that the tools are updated and being made available, and then we ensure that the systems are regularly audited to ensure that they are functional. And then what about the operational and administrative processes? You know, if you read most local and international literature, they talk about the issue of the behavior of the service providers. how their behaviors are not so good. It's not only to the patients, it's also when it comes to data, and we have been taking pains to explore why that is exactly. And one of the ways that we have put in place is to strengthen the integrated supportive supervision process to ensure that we provide the support. We are not going there to insult, castigate, or blame those who work at this facility level, because ordinarily, it's not supposed to be their work to be entering data. How do we support them? The supportive supervisory tool has been developed, and we'll continue to operationalize that at all levels to see how we can use to improve service delivery and then data, quality data transmission and sharing. Then, of course, there's the data quality assessment, which provides the assurance for data quality. And then another important thing in terms of operational and administrative issues is ensuring that we develop SOPs that guide how data should be managed and shared and used at all levels. Not assuming that everybody knows, but ensuring that there's uniformity in data management. Of course, the next one there is capacity of data managers at all levels, and then infusing technology and innovation into data collection, management, and data use. I've just explained some of these in details. So next slide, please. So for data governance structure, at all levels, there must be something we call technical committees that work on data. And then that coalesces into technical working groups where technical people sit down to hold meetings and deliberate on issues of their data. And then as you go up, we have established what we call the National M&E Technical Working Group. That's where we sit down and discuss issues of data. So there are those working on surveillance data, people working on periodic data, routine data. The periodic data includes surveys and assessments that you do periodically. And then when all this come together, we sit and talk about them at the National M&E-TWG. From there, we pass issues to where what we call, the body we call the Head Data Consultative Committee. It's fully established and functional. And then once issues are deliberated upon, they pass it for approval to the Head Data Governance Council. Now, that's where the Honorable Minister, the Statistician General of the Federation, and the DG of MPC, that's Nigerian Population Commission, that's where they sit to deliberate and approve issues of data. Whether it's our tools that we're developing or anything we are doing, we always pass them through these bodies. And at the moment, we are supporting all states to also set up and ensure functionality of these bodies at the state level. One of the things that we've gotten out of the HDGC, apart from all the tools that we've developed, is the issue of population number. That's what forms the basis, the denominator. For example, for number of children immunized, number of children who are wasted, you use the total population of children in the country. And we went to the HDGC and said, we are continuously having wrong figures because the census, the last census, God knows when we had the last census. And we don't even know when we're going to have the next one. So we told them that we have systems in place that can help to count the number of children born and estimate our population near accurate. give us approval to be able to use that for the health sector. And we got approval 3 years ago at the HDGC. In terms of data policies, we have what we call, for the second strategic health development plan, we now have standalone M&E plan, which is a guide for everybody working in the data space. We also have what we call the health information system policy that tells you this is how to manage platforms, this is how to set up platforms, and this is what to do if you're managing health data. Now, quickly to what we are doing in terms of integrating systems. The DHIS2, according to National Health Information Policy, should be the standalone where we mine routine data from. So we have ensured that the National Data Repository, which is holding patient-level data, feeds from and feeds into the DHIS2. We are doing the same for the electronic TB manager, the Navision, the Community Health Management Information System, the NPDS-RO, and the DHIS2 now has what we call the Health Facility Registry, where it counts all our service delivery points. I'm happy to talk more about those integration. An interesting tool and innovative tool we have also developed is the ISS DQA Facility Assessment Tool. We call it the Digital ISS. What that has done is we have taken away the issue of using paper to conduct ISS, to conducting ISS on your mobile phones. So we want those at the local government level at any point in time, as prescribed by the SOP, to conduct ISS, to support your service delivery points and provide that mentorship that's needed by the facilities. So no matter what program you are, you can use that ISS tool, and it's open source and available on the ministry's website. If we go to the next slide, you will have a snapshot of what that looks like. Like I said, it's open source, it's available for everyone. Once you make the request, we will give you or point you to where you can get access. And once you log on to that system, you have all the blank forms, and it's something you don't need any specialized gadget. Once you have a mobile phone, you have internet, you log on, you can log off and work offline until you are ready to submit. And this is being integrated with all the tools that are being developed by all the programs, the agencies, and parastatals. For example, we worked hand in hand with MPACDA, the technical departments, and all other relevant stakeholders to develop this. And he has been winning awards across the world. So most countries, now I think something that's noteworthy is the result. If you go to 2 slides from this, let me quickly show the results. Once you conduct DQA, for example, this is how the result comes out. And this is a real result that I've just showcased. So what it means is we go to the facility, whether you are state, local government, you can use this tool to conduct DQA. You go to the facility, and then immediately you administer this tool, it will look at those data quality issues and compare them with system issues. And then it will score the facility. So this is a facility we went to, I think, in Bauchi State, where they had 100% on the DHIS tool. By the time we administered this tool, they scored 13.3%. What we then did was to sit down with them, because you can immediately see the problem. Sit down with them, mentor them on how to properly fill the tool, sign off, ensure that we have quality data. And so it will also identify the areas where the gap was, so that when you go for the next, you know exactly where to tackle. It is the same with the ISS tool. Please scroll. It is the same with the ISS tool. We even take pictures, we identify the issues, and in 10, 20 years to come, you can always refer to issues that happen and see how that facility progressed, their data issues progressed from 2019 to 2030 or whenever. I may not have time to demo this, but just to mention that it's there on the ministry's website. Once you have internet, go to the Federal Ministry of Health website, health.gov.ng, go to Department of Health Planning, Research and Statistics, and you will see all the platforms and everything being done around data. So I'm going to talk about capacity building briefly before I end. In 2017, supported by AFNet CDC, we gave laptops to all the local government M&E officers across the country. And we left, yeah, thank you. And we left officers to support the state. And what we saw was that that was the time we had some of the best reporting rates in the country. Unfortunately, have those laptops been replaced after 2-3 years? No. But what it showed was that if you empower the states, or the states get support to be able to report electronically, we would have improved significantly our data quality. In terms of technology and innovation, again, if you go to the Federal Ministry of Health website, you will see that there are a lot of platforms, dashboards that we are creating. We are automating a lot of systems. We are supporting states to do data reporting. The integration of the systems is also being undertaken aggressively. So when we make requests to donors, we are telling them, please just support us to be able to automate our system, to be able to create these fantastic dashboards. There's a particular one that probably will be launched by Mr. President when we submit the annual health report, the multi-source dashboard. Department of Family Health, we are happy that they are using that dashboard heavily. The World Bank, most donors have come to us to say they want to support that dashboard. And what we have done with that dashboard is to ensure that we are able to compare survey data with routine data. Gone are the days, like I said, when you go searching for information. Oh, they said they did the NDHS. Where is the report? And all that. You just go to our website, it's open source, and you see the multi-source dashboard with beautiful colors, and it's showing you what exactly the results were. Even our facility assessments, health facility survey, it's all there on the ministry's website. Now, lastly, before I leave, I would like to talk about using the performance-based approach. One of the things we have seen in our data platforms is that when facility and service delivery people are incentivized, like I said, it's not supposed to be their work. The quality thing to do would be to engage data clerks in facilities so that they focus on data entering, doing basic analysis, and ensuring that that facility, that service delivery point, uses data for managing things as part of the quality improvement team. That's what's going to happen in the BHCPF. And then when they share that data, with the local government, with the ward, there should be ward committees that should sit down and look at those data, hold meetings on them and say, what does this mean for our ward? What does this mean for our community? And they are incentivized to do that, and they are happy to do it. That's part of the performance-based financing approach. And then you have independent verification bodies that have been commissioned, coming to ensure that there's someone looking at those data. Like I said, it's a pity I won't be able to do the demo, but it's there on the website. What we saw was that those facilities that use performance-based approach, even when we went to do DQA, data quality assessment, their results were fantastic, 100 over 100, because they had people coming to look at their data. And not just coming to look at their data, but they were also incentivizing them for doing the right thing. And I think that worked fantastically well. So in conclusion, if we want to have quality service delivery, we must put in place measures to ensure that we are using not just data, but valid quality data. And that will ultimately result in quality health outcomes for our people. So that every woman and child, if you like, you include the men, will get quality service delivery when they go to our facilities. I'll stop here. Thank you very much.
I think it really must be a World Award winning team. Give him a round of applause once again. That was a great one. Wonderful presentation, great indeed. I have learned so much that I even feel I should go for, maybe we should go for a test or exam here. Honestly, it's been so comprehensive. So, Dr. Anthony, we thank you and we appreciate you indeed. And I know if given the time, you will continue, you know. Honestly, I am sure of the fact that, yes, indeed, we have obtained so much from this presentation. We appreciate you so much. Now, we will quickly take some questions and answers to our esteemed participants online. We thank you for your participation. We know you are still there. We appreciate you. We welcome questions, you know, from you over there. Thank you for your participation. So many hands up here. Yes, I know. Let us start from behind. Yes. Sorry, we're going to bombard you with so many questions, and I know you are capable.
Yeah, thank you, Doctor, for the presentation. So on the issue of current and timely data reporting, so we have an issue of missing data element on the DHIS. How are we going to sort out this issue particularly? That's just the question. Thank you.
Thank you very much. My name is Dr. Zainab Muhammad Idris Kwaru, the project coordinator on the ANRiN project for Kaduna State. I would like to commend this presentation and to also make a few comments and ask my question. We all know that data is very key, especially in planning and decision-making processes, and it's even more so when it comes to nutrition interventions. Especially some of the key examples that you have given us in your presentation. For me, I think a lot of the data that we are currently getting from the platforms that you have pointed us to are sometimes not very representative of the reality of what should be, especially if you look at the component of community activities and some of the data that are generated from that level. A lot of that data does not go into the registers that are eventually entered into the DHIS. I do not know how far your unit or your department has gone in terms of harvesting some of that information to improve, you know, some of the key things that needs to be programmed for. A lot of discussion had happened, I think, over the years. There are certain attempts to see how community level data can be captured in the DHIS. I don't know what progress we have made in that direction. It's very important for us to have an insight into what you're doing to address that gap. And then a lot of the things that we do are based on estimates.
rather than the actual information that is required. You've talked about the challenges, you've talked about some of the key bottlenecks that we still have, but what really can we do to ensure that we have a seamless way of getting the repository of information that is required to improve our planning and programming? Coming to nutrition more specifically, we also know that a lot of the indicators that need to be tracked are nowhere to be found if you look at our administrative data. So again, what plans do we have to ensure that some of those nutrition data are captured in the current system that we currently have? Thank you.
Yes, please. We have our online viewers sending forth questions now. Do we have questions from our online viewers? Okay.
Thank you, Dr. Adege, for that wonderful presentation. It was really, 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 really very interesting, I must say. I just wanted to find out, because I just got to know that you have this on the platform, which is to disseminate this information to we at the national level, so that we know where to go when we need to look for data to inform our programming. And secondly, too, is there a way that when you get this sort of data, the way they do at the facility level, you hold meetings and troubleshoot? Maybe at the federal level too, you could work with program officers in different divisions and departments and look at this data that has been generated and see how we can inform our policies, our guidelines. That would be another good way for us to also make use of it at the national level. Thank you very much.
Okay, thank you. I will start.
I have a concern before you.
Okay.
My concern is this: is your dashboard at the national level linked up or connected with the national finance, national planning, and budget and national planning dashboard? Because I understand they have a national dashboard at that level. How do you have any link with that?
Thank you very much. I will start with the last. Yeah.
Like Auguste presented yesterday, that they've not been able to migrate. So I don't know why those migrations should still be happening, because I know 2019 DHSS2 is at the state level, but Kogi is still having problem to access that. And most times they've been complaining about the missing data. So I don't know how, because I was even expecting our focal persons to speak on this. It's an opportunity for them so that this missing data can be resolved.
Thank you very much. So
thank you so much. Can we ask our questions too from online?
Okay, in your presentation, you made mention of the importance of having accurate denominator when you want to program. But we still have issues with population. In some programs, you will find out that they are using the GIS population, but in other programs, they are using the census projected. So I think it's important we have a uniform population when designing the program. So what can you say about that for states? Thank you.
thank you very much. Okay, so I will start by saying that in direct response to your question, that we need to ensure that the health information exchange is robust. There's adequate feedback. Like I said, we did get about 3 years ago approval to be able to use health data for health planning. So we've gotten the approval, which means we don't have to rely on the last census, data for the last census, because it has really been giving us issues. The immunization people, I'm sure even the nutrition people, most especially, if you work with women of childbearing age and under fives, you see that the census, I mean, the census was, I think the last one was 2006. You can't be using that in 2021 to plan. So we will continue to engage with the states. We have what we now call monthly bulletin. Unfortunately, we are not able to, I'm just about to publish the one for February. We are not able to publish regularly, especially for the routine data, because we have to wait until the 15th of the previous month passes. And even then, you don't have all the information in there already to be able to publish the bulletin immediately. But we are working around that. Now, to the issue of migration, I will need to quickly explain this, that our work at the federal level is to review tools for data collection, develop tools for data collection, and then with support from our partners, we go ahead and print what we call seed tools and distribute to the states. Now, the states are supposed to actually print their own tools. Now, we understand that it's not your fault if the governor doesn't see the need to earmark money towards the printing of tools, and you don't have partners to support your state, it becomes a huge problem. Once the governor and the state says, oh, we didn't capture it in our budget, what can you do? So you have issues of facility people actually using notebooks, and we don't want that burden to be on them. And that's why, like I said, part of what we have done is we have secured support for states that we can support. We are aggressively rolling out mobile phones and tablets to facilities. This is just to save the state from all these problems. But first, they need to be able to signify that they are ready to migrate, and then we'll come and give them all that support, including training. But just to say that states that don't have partner support are really, really suffering. And we really have to sit down and have conversation around what to do. For finance, Federal Ministry of Finance, Budget and National Planning, I keep saying, there's no way your father gives you money, whoever gives you money to go and carry out an activity, whether it's to go to school or whatever, and then you don't bring report sheet home. That's the problem we've been facing. How does somebody give you money? Federal Ministry of Finance gives you money, and then you don't report back. Currently, what we are doing is we are fine-tuning our KPIs, the key performance indicators from all the programs, all the technical departments and everybody. We have submitted something to Federal Ministry of Finance, Budget and National Planning, but we are also building capacity around the programs to say, this is how you develop KPIs around the money that have been given to you and your core mandate. So we are currently working on that, even though we have submitted something, but continuously it must be reviewed, and we are championing that process. Now, for dissemination efforts, like I said, we have technical committees, we have the national MNET WGs, which feed from all the technical committees and the various TWGs. Now, when people go to their churches, they say they cast and bind monitoring spirit, but that's what we are. So if you, first of all, stop binding us, then we are able to do our work. In every technical unit, department, in the ministries, agencies, parastatals, the state, you should have responsible persons who feed back and share information appropriately. And that's why I'm taking the pains to emphasize that everything we now do, we don't need you to come to us begging us for data. It's there online. We analyze our data monthly and put it online. Like I said, I'm happy that Family Health, they now use the multi-source dashboard for planning. Maybe some divisions in Family Health. But we also took measures to ensure that we put dashboards as big as this in the minister's office, Minister of State, PAMSEC, and then we had maybe screens that are 55-inch screen, I can remember vividly, in Department of Family Health, Department of Public Health. We sent 2 dashboards to MPSCDA like this, so that the decision makers can see their data. And we encourage everybody to do the same, because you don't just collect data, transmit it, and you say that's the end. Even at the facility level, at all levels, data must be used. And we are now establishing what we call a help desk, so that when we see issues on the DHIS2, we report back to the state. For example, I give a very clear example. Bauchi State, we saw in a small community that there were 7,000, about 6,000 maternal deaths in a facility. We quickly zoomed in, checked how many people in that community. There were very few people, less than 500. So how do you have 6,000 maternal deaths? So we called the in charge and said, Madam, please quickly correct that. And they said they saw that it was a typo error. Now, the issue of missing data, that question came up twice. Yes, as we are transiting from 2013 to 2019 tools, we are also optimizing the DHIS2. That's why we are having some issues, but all that will be resolved. They are still working. You will see the notice on the DHIS2. We're working assiduously, and we're getting all the most of the support we need to optimize the system. Like I said, we do regular system audits, and then we see the need to move around indicators. But that does not mean, like I said, that those that you have, you shouldn't be reporting on them. The progress on the CHMIS. The CHMIS was a pilot. We've come to the end of that pilot, and the lessons learned is part of what informed the chiefs, like I said. And what we are now doing is we have gotten support from UNICEF, if not for the COVID and some other partners, to actually start the process of ensuring that we have robust space to collect community data, because we have seen that there's more data that's going to come from the community. And then we will now link that to the facility data. So in this community, in this Gariki, when you say 100 children, 100 babies were born in the month of February, what it means that you have combined those that were born in the facility and those that were born at home to say 100 babies were born in Gariki for this month. I think the use of estimates is the last. Let me just say that this is part of the reason why we emphasize on the use of technology, innovation, and then most importantly, building capacity at all levels. Now, we are able to, as it is now, if we build capacity, do what we call modeling. Because where we are realistically in Nigeria, we will not be able to immediately get all the infrastructure and everything to collect accurate data. There's politics in it. There's politics, a lot of politics involved in working with community data. Some people don't want you to report exactly how many families are within a community, maybe for election purposes. That's why we had to go get that approval. But if we are able to do very robust modeling, we're able to even model and say these are the number of children who will be born based on this number, that number, that number. But that also have to come from quality data that is being shared with us. And that also have to do with having capacity at the various levels, whether it's at the agency level, at the ministry level, having real statisticians, biostatisticians, and all that, who can do that appropriate modeling with all the their capacity being built. I think I'll stop here. Thank you very much. Okay. Online.
In viewers online, I think it's important you address those issues also. Please, one of them is, please can you confirm if we now have nutrition indicators included in the DHIS 2. Last year, some of the indicators were missing. And now with progress with the ANRiN project, this needs to be addressed. That's one of the questions. So I'll just read them all out. Is it okay?
Yes.
Okay. It's a common knowledge that most of the target population for various interventions are estimated. And most often, when the real population has been covered, it will still reflect low coverage. How do we curb against data falsification across all primary healthcare intervention? This one is coming from Bill Kisu Abdulaziz on supportive supervision. To ensure accurate collation of data, can it be made possible for supervision on quarterly basis to reach all ANRiN interventions local government areas without making random selection? The last but not the least, given that most of the nutrition indicators are not on the DH, I think it's the same thing as the first. Okay.
Okay, thank you very much. Currently, with the 2019 tool, we have about 13, if I'm not mistaken, nutrition indicators. Okay, and that spans from, if you like, nutrition for pregnant women, children between the ages of 0 to 59 months that have received nutrition growth monitoring and promotion services. There's also children that are growing well according to the prescribed rate. Those receiving exclusive breastfeeding is there on the return. This is even in the monthly summary form. So if you have 13 robust indicators on the monthly summary form, that means nutrition has been given a place of priority. However, like I said, and this is very instructive and practical, we have to work with the quality improvement teams. I'm not saying go and set up your own team. We are now having in facility quality improvement team. If you as a program now go to a facility and see that they don't have, then you can help to set up one in that facility. But if they already have, strengthen that team to say, please, let's check to ensure that you have filled out all these indicators. Why would you weigh a baby and not report it? I mean, that's even the easiest thing to do. So we have captured nutrition indicators robustly. Let's start reporting on these key ones. Then when it comes to data falsification, I would tie that with the ISS. Like I said, we have passed that stage where we go and say, why are you falsifying data? Why are you doing this? Why are you doing that? In the first instance, it's not the person's place. So if you want to support that facility or community, engage a data clerk in that facility or in that community intervention, and then give the person a mobile phone. The mobile phones are so cheap these days. And then when it comes to the ISS, like I said, we have developed an electronic tool. I don't even subscribe to the issue of doing ISS quarterly. It's because maybe there's so much money, so much resources involved in the conduct of ISS, as it were. But now with the tool we have developed, we want practically the local government M&E officer, when you pay a visit to the facility, if you don't have a phone, get support. Now we know that, okay, maybe they need a mobile phone, a cheap Android phone, as cheap as less than 10,000 naira. They just download the app. Immediately they walk into a facility, even if it's every week. It takes less than 1 hour to administer that tool once you're used to it. You just administer, do you have this to work? Do you have that? Do you have this? And once the person clicks on submit, anybody, anywhere in the world can see the results with images, exactly what is happening. You don't need to go to the facility. So that local government M&E officer would have spent only transport, and if you like, some stipends to go there. Then when we sit here at the federal level, or even at the state level, as we are going through the data, we say, there's problem continuously with this facility. Then we call up the state and say, on so-so day, come, let's go and visit that facility. Let's go and visit that ward. So what it means is that both partner, Federal Ministry of Health, MPACDA, and whoever can organize themselves on a biannual or maybe quarterly basis, if you like, and then go and visit the problematic areas. And that will be a beautiful way to be able to ensure that proper ISS is done. But ordinarily, it should be the local government M&E officers. The local government should be able to take charge of the conduct of ISS. And we have passwords, user access for all of them for the new ISS digital tool. You have seen how the beautiful reports, I didn't have time to demo, but please just go online, go to health.gov.ng, and you will see the ISS tool and see how the reports look like. It's just there, just click on reports. Even the forms are smart forms with skip logic. So they ask you the questions, if depending on what you answer, if it's not relevant, it skips it and goes to the next relevant question. Thank you very much.
Historic data will always be available and accessible because currently 2019 data is not accessible on the DHIS2. The second question is this: at what point and how do you validate all coverage data, in bracket administrative, collected through DHIS2, HMIS?
Yes. Okay, thank you very much. I agree with you that
These are the last questions.
I agree with you that those are very, very important questions, especially in regards to the ANRiN. So for the ANRiN project, we recognize that we have lost a lot of data in the past to short-term projects. So we are currently in talks with the leadership of the project, and we have told them that on the DHIS2, there's what we call event capture. Luckily, has also been, the use of the event capture has been approved by the Head Data Governance Council. What it means is that they can set up an instance, and we already introduced them to HISP Nigeria, set up an instance on the DHIS2. What it means is that that event capture will capture everybody that you see during the project. If you like, you see the person 10 times a day. The event capture will capture all those events, capture that child or that woman with the entire family, the entire household, and the neighboring households, if you like. So you see, it's a very, very powerful tool. That's what we're using for the chips at the moment. So that can be set up. We are currently in talks with them. And the challenges we're having with the CHMIS is going to be resolved. There's a meeting set up for this week with UNICEF, and we're introducing the ANRiN team to them so that we ensure that the CHMIS is working, and eventually this will be harmonized with the DHIS2, the national instance, so that we have complete data. So that's what's being done, and I can assure you that once that is done, we have the National Data Repository, which we're also linking the DHIS2 to, where we can store data for us the next 50 years. All we need to do is to continue to support the expansion of that system, especially as community data comes in. Now, the law is that we cannot host any data, Nigerian data, outside Nigeria, especially patient-level data, like I said before, because you encounter people, children, women, we cannot afford to expose their data by law. Otherwise, all of us will run foul of the law. So, like I said, what is being done is to ensure that they are captured using event capture, and that will be linked with the NDRO, where their data will be stored for the next 50, 100 years. But we'll just continue to optimize and ensure that the system is robust enough to accommodate that data. I think that answers that question. Thank you very much. Thank you very much, and thank you for having me.
Dr. Anthony. It is indeed heartwarming to know that we now have a significant reporting rate at all levels in our country. And on that note, I want to thank you for this great presentation. I want to thank you for all your efforts, so far, and of course, your success. We applaud your success and we commend you greatly. Thank you so much. Can you please give him another round of applause? For online for our online viewers, I think to Dr. Sylvester in particular, we want to again apologize for the shift in time of your presentation. Again, we are having another shift. The World Bank has been with us since yesterday. They want to just quickly give a goodwill message to the group. Dr. Sylvester, again, we apologize. Immediately after tea break, you will be on board. Thank you for your patience. Thank you so much. Can we have the Dr. Ridga, the World Bank, to give us
Good morning again, everyone. Nice to see you all here today. I won't take up much time because I think all the ceremonial parts of this are done. It's really just to share a bit of our perspective as to why we're here today and sort of be forward-looking about what we can take with us as we leave at the end of today. So as everyone has said, the minister said it yesterday, I heard Dr. Onwu this morning talking about the pertinence of us investing in nutrition programming in the country, specifically because we know that it's not just at an individual level that the first 1,000 days counts, but that there's an economic imperative that if we are able to improve on malnutrition and specifically the very high stunting rates that the country has, it means that we have younger people who are young children who are growing up to be able to, one, attain higher educational outcomes, thereby going into an economy and being higher income earners. This means that when you start looking at things like what they call the gross national income, that's based on per capita incomes and so on, that it sort of culminates into collective prosperity for us as a country. And so what we're doing here today, no matter how little, is a drop in the ocean, building to that prosperity for Nigeria tomorrow. And so here we as ANRiN took this life cycle approach, right? That we know that the first 1,000 days starts in utero, when the mother is when the child is still in womb and is growing and developing. That's when the brain development starts. And therefore we have to start to address those issues of nutritional deficiencies, micronutrient deficiencies, and all of that from the mother, from the level of the mother. And so we built in this, along with the Ministry of Health, nutrition sensitive antenatal care package. It's a thin slice of the broader ANRiN project, right? The broader ANRiN project is really focused on delivering a broader set of prevention interventions at community level. So out of a $232 million project, $181 million is going to those community-based interventions. So this facility side is complementary. It just happens to be, and I heard a lot of people asking yesterday, it just happens to be that these are the first and early results that the project has. More results are yet to come. But this JARC and the annual results conference and the annual reporting is deliverable, it's mandated, it's an opportunity for us to share our learning. And this is why we brought the modest results that we had at state level to share as a group. And I will say they're just modest results. You saw all of the states, they said they exceeded their targets. It may be few facilities, 9 in some states, 12 in some states. They've really catapulted in this year already. Many of them are already implementing in 100 facilities and over and above. So I think we're close to already 1,000 facilities across the implementing states as we speak. And that is to continue to expand exponentially over the next few years. Um, and the platform of the JARC allows us to, as I said, share lessons. It's about the how-to. We're doing a lot of programming. We want to invest in the right places or the right components or aspects or interventions. We have the evidence. We know what the evidence says about which interventions are effective. But when it comes down to operationalization, we still have perhaps some learning to do. And that's the opportunity that the JARC provides. That we, one, as a project, we proposed a few things. Are they working the way that we said that they should? If they're not working, what changes can we make? If they are working exceedingly well, how can we start to scale them up? What's the pathway to that? And then over and above that, when we build up that evidence, year 1, year 2, year 3, year 4, for the life of the project, is there sufficient evidence to try to push this either as a national approach or build it into national policy? Where is the do we have sufficient evidence to say this is a way, this is a pathway that we can all take? And this is especially important because, as Dr. Onwu was informing us yesterday, there are discussions around the Basic Healthcare Provision Fund and integrating nutrition into that. So we need to be in a state of readiness to say we know how to do this very well and very readily. And so I think that's the essence of today. So I'll just say from the World Bank side, I think we've been partners, colleagues, and friends with the FMOH and MPHCDA. The real work that's been done is by you, the state focal persons. We are here learning from you because you're the ones, boots on the ground, that are on a day-to-day basis within the system, frontally engaged with the clients and the providers. But also at the managerial level, we have our FMOH and MPHCDA colleagues who have worked tirelessly. So I heard someone say online today that I work tirelessly. It's not me, and I'm not one person. I'm a team, and our team represents our organization. But over and above us is the folks in blue. If you see them over the weekend, they were all here from morning till night. They've been online, sending us emails in the middle of the night, trying to get this opportunity together, this platform together for us to share our learning. And this platform will feed into the broader work that the nutrition division will have to do over the next 3 years, which is around knowledge management and learning for nutrition in the country. So I just want to say, lastly, thank you to the Ministry of Health, to the MPHCDA, our state level colleagues, the PCs that have been here, the state focal persons especially. Thank you for all your hard work and for the learning that we've gleaned from you from yesterday. And just to say that it's the beginning, and I think we need to, as we've scaled up to more facilities, definitely go back and strap our boots and try to really boost our performance. And lastly, maybe to address an issue that seemed to have been coming up a lot about comparison, ANRiN versus non-ANRiN. So this is not an experiment, it's not a pilot, it's not a real control, but we just wanted to see where there are no interventions per se or different types of interventions. How are we faring? If of course we see that in those compared facilities, there seems to be better performance, then we're going to be reaching out to our colleagues in those facilities and saying, what are you doing? Because we want to do it too. So that's the essence of comparison. It's a bilateral thing. It's both ways. It's not in any way to say, therefore, ANRiN, FMOH, and PhD World Bank project is doing better. No, it's a learning opportunity, and that's why we're doing the comparison and looking at trends also over time. So let me stop here. There's a lot to say. I wish us successful deliberations for the rest of today. I hope that it's been a useful engagement for you since yesterday. Thank you.
Thank you so very much, Dr. Rika, for that goodwill message to both participants present here and, of course, our online viewers. And on that note, I want to say Can we go for break now? Do you think is break ready? Tea break ready? Is tea ready? Can we go for tea break? Okay, okay. Please, we can go for tea break for 20, 25 minutes, and then we'll come back again to resume for the next session. Online viewers, it's tea break time. You can also go for tea and then come back 20, 25 minutes time. Thank you.
Hello, you are all welcome back from the tea break. Hello, good afternoon. Is it yet afternoon? Hello, welcome back from the tea break. Are we together? Can we have a house, please? Welcome back. Welcome back from tea break. Dr. Sylvester is already on board, so we need to settle down quickly and listen to this virtual presentation. It's going to be a virtual presentation, so we need to listen attentively. We're all aware of the fact that nutrition-specific and nutrition-sensitive aid lead to reduction in the proportion of stunted children, right? Furthermore, with an increase in funding nutrition-specific with the highest specific countries with the highest burden of malnutrition experience sharper reduction in the proportion of stunted children. We therefore need to address early childhood stunting and improve other maternal and child health indicators now that attention is being fully given to improve nutrition. That is the basis of his presentation this morning. And so we are going to link up to Dr. Sylvester Igbedio, who is very much with us. He is, can you put his profile on the, it's a whole lot. Dr. Sylvester Igbedio graduated with a bachelor's degree in biochemistry, a master's and PhD in 1982 and 1988, respectively, in human nutrition, all from University of Ibadan, Nigeria. He worked briefly in Ahmadu Bello University, Zaria, before moving to University of Agriculture, Makadi in 1991. I think we have that on board. How we just need to quickly tell you that Dr. Igbedio led the UNICEF Enugu team with membership drawn from health, nutrition, education, protection, and sanitation to develop standards of early childhood care in Nigeria. In 2010, he led the field office team that collaborated with UNICEF country office and other partners to develop the first guideline on a biannual national child health week called the Maternal, Newborn, and Child Health Week. The first guideline was actually developed in Owerri. It is indeed my pleasure to have you here with us, Dr. Sylvester Igbedio. He's going to is he already with us? Okay, Dr. Sylvester Igbedio. Dr. Sylvester, are you now with us?
I've been with you since, but can you hear me now?
Honestly, we thank you for the long patience. We thank you so very much. Now the floor is all yours. Thank you.
Thank you. Thank you.
Thank you so much. The floor is yours for the next 10 to 15 minutes.
Wow, thank you. Good afternoon, the moderator, Mrs. Gabriel. Thank you for your kind words. And fellow participants. I hope everybody can hear me. I would like to express my gratitude to the organizers for extending this invitation to me and I've enjoyed this conference, especially the presentation made by one Professor Bina on resource-based financing. Quickly, I will go to my presentation. My presentation simply talks about how do we exploit, when you talk about leveraging, how do we exploit nutrition sensitive and specific approaches for optimizing maternal nutrition in pregnancy and lactation. It's not moving. What's going on? Okay. With the first slide, most of us, we are familiar with this, that poor nutrition in pregnancy and lactation is a concern, and deficiencies of energy, protein, these nutrients, the critical nutrients, iron and folic acid, calcium and iodine, in pregnancy and lactation complicates brings about maternal complications and even mortality. And such complications are birth defects, low birth weight, and newborn mortality, and so on and so forth. Well, the anemia, which results from deficiencies of nutrients such as iron and folic acid, is an important risk factor. Even though I'm aware that hemorrhage, eclampsia, they are major causes of, among the major causes, even abortion, they are the major causes of maternal mortality in Nigeria. But these nutrients contribute, they are risk factors because they contribute a lot to what we see. Calcium deficiency during pregnancy, for example, increases the risk of pre-eclampsia, and is also another cause of maternal mortality. So we need to improve nutrition alongside good antenatal care for our adolescents, women of pregnant women and lactating women. And generally, this particular, we know that malnutrition remains a significant health problem in Nigeria. And even some scholars even say we have triple burden of malnutrition, which is manifesting both undernutrition, micronutrient deficiency, and obesity. Alongside diet-related non-communicable diseases, they are also on the increase. The cost of malnutrition, they are high, because if not, we will not be gathering, we will not be doing what we have been doing for the last 20, 30 years. They are high, leading to morbidity, increased mortality, decreased cognitive ability, poor educational outcomes, lost earnings, especially in terms of productivity, and in terms of the GDP to the country. Why are we concerned? Which is the rationale? If you look at, I try to use the figure, the maternal mortality rate. It has fallen over time from about 1,200, well, from the year 2001. I use that from 2001 to 2018. It has steadily fallen. Even at 917, it is still too high. Nigeria accounts for about 19% of the world's total burden, which is something that we need to be concerned about. I try to define maternal is the number of women who die as from related causes while pregnant or within 42 days when pregnancy is terminated by 100,000 live births. And I said that anemia contributes greatly to this. That is an example of nutrition status. Comparatively, I used a figure which will come in the next slide. If you look at the rating where Nigeria is placed, I think it's unacceptable. Why do I say that? Countries like Somalia, often referred to as a failed state. Central African Republic, Afghanistan. These last two countries have been at war for over 2 decades. And yet they have better maternal mortality than Nigeria. The leading causes of maternal mortality in Nigeria, I just tried now so that I can define it. So I'm not accused to say that obstetric hemorrhage, eclampsia, complications from safe abortions. Yes, but there are risk factors, which are anemia, anesthesia, and some where that, of course, we also know that unbooked cases, 98% of women who are unbooked, this is where the danger sign is also around. And those who are admitted within less than 48 hours before the delivery. But in order to tackle anemia and other forms of malnutrition effectively in pregnancy and lactation, we need to look at proving specific and sensitive nutrition interventions, which the moderator talked about, that the reason why this presentation is necessary is that we need to go beyond the nutrition specific. Why? Because the nutrition sensitive provides the enabling environment for nutrition specific to be maximally utilized. Again, this is supported by the Lancet series on maternal and child nutrition that talks about accelerating progress in nutrition will require more aggressive effort, where in fact it used the word coupling, that is bringing together nutrition specific interventions, which most of us are well aware of, as I'm sure that the 90% of the audience work in health facilities. Nutrition specific, that's what we are, but there is also nutrition sensitive that will provide the enabling environment for nutrition specific to work. By the way, two of the most important achievements in nutrition till date, iodized salt, vitamin A fortified, that is fortification, not entirely in the domain of the health sector. So we need to put this in context, that we need both nutrition specific and nutrition sensitive, couple them together for us to make sustainable progress. Sustainable progress. And look at what I talked about, the figure. Look at where Nigeria is, number 4. Look at Central African Republic and Somalia. They have been at war for the last. In fact, Somalia has no central government. It is referred to as a failed state, and yet has a better maternal mortality. But this does not completely say that only nutrition contributes to it. No, I have made that point, so I'm not accused of. But anemia contributes greatly, becomes a risk factor in hemorrhage, which is perhaps the number 1 cause of maternal mortality in Nigeria. But this is just now talking about nutrients requirements. From a nutritional point of view, both pregnancy and lactation, they are the most demanding physiological situations in a woman's life. We already know this. Why? It is because all nutrients are required in higher amounts, whether it is protein, whether it's energy, whether it's B vitamins, iron, folate, during pregnancy and lactation, because they are basic both for the health of the mother and the child. And the first few months are usually most critical for developing infants, because during this time, that is when you see development would, during this period is where you have a lot of development in terms of brain, arms, legs, internal organs. And so we need to be to take care of what the pregnant woman, the woman who is carrying the fetus of the child, what she eats or what she consumes. Since successful pregnancy depends on nutritional status of the mother, and we also need to be concerned of women, generally women of childbearing age, and also adolescents. Adolescents, especially in areas where early marriages, they are common. And if you look at the map of Nigeria now, you'll find that it's not only restricted to the where we used to think that it's mainly from. It goes around the whole country, where adolescents, where early marriages are common. We need to also be concerned about what they consume. And I try to present the figure for when I say 68% and 58% of women were found to be anemic in the last NDHS 2018. And you know, anemia places both mother and child in danger because it increases the risk of blood loss during labor and can result in preterm delivery, low birth weight, and perinatal mortality. So because of this, pregnant women are advised to take iron folates as supplements apart from consumption of iron-rich foods, and also reducing intestinal worms by taking deworming tablets, supplements as it were. I put there the requirements for pregnancy are those that are needed to ensure growth of the fetus, that is energy for the proper growth of the fetus, and associated maternal tissues. It provides increased metabolic demands in pregnancy, maintaining adequate maternal weight, body composition, physical activity throughout the gestational period, and provide sufficient energy for the woman or the pregnant woman in her daily activities, and of course during lactation when she delivers. The next slide is I'll just skip through it, but just to say that these are essential minerals and vitamins, B vitamins, because of the roles they perform as coenzymes. Vitamin A, they are needed because of the importance in tissue growth, folate to mature red blood cells, vitamin D to ensure absorption and utilization of calcium and phosphorus for fetal bone growth. So these are critical: vitamin A and C, B vitamins, folate, and vitamin D. Calcium along with phosphorus and vitamin D, essential, I just made that point, for fetal development of bones and teeth, as well as for the mother. So for proper clotting of the blood clotting. Iron, which is perhaps the largest micronutrient deficiency, is essential for increased hemoglobin synthesis, for greater maternal blood volume, as well as for perinatal storage of iron. That is the iron that the baby falls on when the baby is delivered for the first 2 or 3 days. Iodine is also essential for producing more thyroxine that is needed in greater amount. Thyroxine produces the hormones that is needed in greater to control the increased basal metabolic rate during pregnancy. I just felt I should just let's go to the real thing now, the specific interventions. And I tried to define it using that IFPRI 2016 that talks about that these specific interventions, which a lot of us in the room there are those that address immediate determinants of fetal and child nutrition and development. We are quite familiar with this. They include vitamin A, zinc supplementation, exclusive breastfeeding, dietary diversity. In fact, I've heard a lot about dietary diversity promotion, demonstration of cooking demonstration to improve, to show the mothers in those states what they should be eating. And finally, I also mentioned food for, that is, these are specific interventions that target immediate causes of undernutrition. They target immediate causes of undernutrition, inadequate dietary intake, and ill health. Those are the two key, they target immediate. When we come to sensitive, we'll be talking about how they provide the enabling environment for the specific to thrive better. And the 2013 Lancet series on maternal and child nutrition recommended 10 direct interventions that should be implemented at scale in countries with high rates of undernutrition, so that if these are implemented, we could reduce stunting. That is what the Lancet is saying. We could reduce stunting by 20%. Currently, Nigeria's stunting rate averagely is 37%. In some places, it's up to 54%. In spite of progress, there's a depth of information on how we should scale up and how to sustain such interventions. And in the next two or next slides, I'll be showing, just projecting those interventions that have been suggested. Now, if you recall the presentation of Professor Obinna, he was talking about the resource-based finances and talk about set of interventions. And he talked also more about purchasing this, how do we purchase? What interventions should we purchase? Which is a little bit similar. That is one question that we need to ask. What is this cost of scaling up? Yes, it is good to scale up, but economists will tell you that what is the cost for you to make decision to say this particular intervention, because of the cost that it has shown, we should be able to buy it. And that's why I use the word, what will these investments buy? And in answering this question, Shekhar and his collaborators in 2016 provided analysis in 4 sub-Saharan countries: Democratic Republic of Congo, Mali, Togo, and Nigeria, which showed that I'll be showing it in the next slide, that when these interventions are implemented, they are cost effective. How did they do this? They use cost effectiveness models, that is modeling cost effectiveness using different scale-up scenario, 70%, 60%, 90%, different scale-up scenario. And through that analysis, it brought out the impact of investing in nutrition interventions that can be maximized under budget constraints. Why is this necessary? It is necessary to convince political leaders to make a decision, not only to support, but to sustain nutrition-specific interventions. In other words, by the time the ANRiN program winds up, our political leaders, especially in these 12 states, they should be able to make a decision. If what we have been seeing in the last 2 days, presented by program team leaders in these different states, on where ANRiN interventions, how it has taken the nutrition outcomes higher than when there was no particular ANRiN intervention. So it is necessary. That is why I use the word, we need to be able to come, because if we don't look at it cost, then we might be running into a problem. It is good, but we need to look at the cost. So the work of Shekhar and his collaborators demonstrated that scaling up a set of 10 critical nutrition-specific interventions is highly cost-effective. When considered, this is the catch, either as a package or as individuals. In other words, if a particular state cannot implement the 10 critical, maybe after I'm talking about after the post ANRiN, they can look at some in the individual interventions and go for it. Based on the modeling results, investments will stay, will save $115,000 in Togo, $509 in Mali, $2 million, and $6.3 million. What does it mean? DALIS is disability, what they used to adjusted life years. Is a measure of overall disease burden, and that is expressed in the number of years lost either to morbidity, disability, or even death. So it's a measure. It's just used as a measure. So you can see the 6.3 DALIS, which means that the number saved in Nigeria as in due to ill health, disability, or even death, they're about 6.3 when used. Now let me go to yes, I was talking about this. If you look at the double asterisk, it talks about the one that are very cost effective. These are just examples of them. When we come, you see community nutrition programs for growth promotion. So we ask ourselves, what do we do to promote growth at the community level? Vitamin A supplementation, zinc supplementation that is used with ORS to address severe diarrhea, iron folate supplementation, which has also come up in this conference, public provision of complementary food for moderate acute. If you look at this is particularly a challenge, providing complementary food for moderate acute malnutrition. And in all, aside from Nigeria, in all other, it was just only cost effective. So it might not be what you would want to go for. But community-based treatment, that is CIMAM, was found to be highly cost effective, at least in Nigeria and in the other sub-Saharan countries. The second slide on this, what will this investment buy? And you have heard there was a speaker, I think from the World Bank, that talked about adopting the life cycle approach. So the 10 specific interventions cut across the life cycle to address undernutrition, to address micronutrient deficiencies in women of reproductive age, pregnant women, were also modeled, including neonates, infants, and children, to assess the effects and cost of scaling up. Well, these are the periconceptual folic acid supplementation, that is giving out folate before the women of reproductive age, before they become pregnant, so that we could make such decisions, especially in areas where, as I said earlier on, early marriages, and we could target adolescents. Maternal balanced energy protein supplementation, which simply means balancing the energy and protein supplements that are offered to women, maternal calcium supplementation, and multiple micronutrient supplementation in pregnancy. And continued investment in this to reach poor segments of the population at greatest rate can make substantial difference. I am hoping that in the selection, like we have been told,
Hello, Dr. Sylvester.
Yes.
Sorry to interject. You have 5 minutes more.
My God.
That's an additional 5 more minutes.
Okay, thank you. And okay, let me just, but I'm sure you can read it up later. Now, this is a conceptual framework for modeling women of reproductive, so that you can, on the left-hand side, you will see for adolescents, on the middle, you will see women of reproductive, that is, the interventions is just a conceptual, it's a framework that we can borrow or adapt from. And you can see the malaria prevention in women, and maternal deworming and obesity prevention. And all will result in decreased maternal and infant morbidity and mortality. And would finally, if you look at the arrow below, increased work capacity and productivity. That is very critical. And of course, economic development. So that we see interventions, modeling from an economic, apart from the health, the moral imperative of keeping people healthy, people alive. As we say, nutrition is a right, health is a right. We also, for our policymakers, who will make final decisions in terms of resources, they also can see that there is economic development and increased work capacity and productivity. I've been told I have to quickly, these are the effects of packages. Optimum maternal health, I just try to put, they are all borrowed from Lancet Maternal and Children series. And these are the effects of packages when it is 95% at confidence in the interval of 91, and at 90% coverage, data and number. Okay, well, you can read this one later. Oh, well, let me talk about this. These are the interventions I earlier mentioned about, and I said these ones can be delivered through the health sector because and most of us are familiar with this. You know, all these interventions from 1 to 10. These are the middle column describes which most of us are also familiar of, and the targets are the last column. Let me hurry up now. That this particular talks about the composition of human milk is fairly constant and hardly affected. But when a woman's diet is deficient, you know, we need to vitamin A and D and thiamine could be affected. So why am I bringing up this? At each postnatal visit, both the mother and the baby, when our health workers examine them, they should give them advice on diets of both mother and infants, how to improve them. I'm quite glad I heard about some presentations that were made yesterday along this line on teaching mother what to do. And the final one talks about proven interventions. These are calcium. You can see that. Let me skip this because Now, let me quickly mention this food fortification. I'll just spend a minute on it. You know, it's one of the best ways to fight malnutrition at scale because you improve. But what this can also do is that it makes available, I'm not saying access, it makes available opportunities for people to access, because access can be defined by economic terms. And recently, I just want to mention that TechnoServe, highlighted achievements for the last 3 years at the 3rd annual Nutrition, Food Processing and Nutrition Leadership. You could see the supply of sugar expanding its ability from 31%. And look at the Nigerian population, 96% can access sugar that is fortified with vitamin A, at least from the supply side. I'm not talking about the economic access. Wheat flour, population to 92%. Cooking oil, the vitamin A increased to 28%. And the availability of iodized salt, this one is an old story, 95% of the Nigerian population. Meaning that additional 125.7 million Nigerians will have access to sugar, 73 will have access. This is important because it brings out that there is access. And I'm glad to say that the food fortification that was started in 1996, in which I was privileged to be one of the arrowheads, we are finally moving on this. Nutrition sensitive interventions, let me quickly talk about this. We require these effective large scale programs that addresses key underlying, I mentioned this earlier on, underlying determinants of nutrition in order to help or provide the enabling environment for the effectiveness and also for the coverage of nutrition specific interventions which we have done. There are quite a number of them, but I only looked at agriculture. I will only talked about agriculture and social safety nets and the need for investment to boost agricultural production, keep prices low and increase income is unassailable. That is the argument for that. And so we need to do more on this by supporting livelihoods. This is where I said we need to think both ways, that sustainable nutrition improvement will not come from nutrition specific alone. No, it will come from both if we want sustainable. And earlier results reported, through agricultural sector, social protection, water and sanitation, poverty reduction program. Let me quit because of time. And if you look at this particular, it talks about the effectiveness of nutrition-sensitive intervention. And I'll just be mentioning one or two examples that we have seen in terms of nutrition gardening. I recall there was an effort around this area to start something or to improve on in Gombe. Of course, other states are also doing this, but you can see this has been shown, and I also know that we have some local examples that nutrition gardening increases availability and accessibility of fruits and vegetables at the household level, which is a critical role, which addresses a critical function at the household level. And on the whole, nutrition sensitive agriculture interventions, they improve household dietary diversity, which is what we have been talking about, that we need to diverse the diet of the women of reproductive age, so that they can receive more of those micronutrients and they can receive more of those energy. Now, the social safety net, the second one I want to talk about, is we have examples that provide cash or food transfer to poor people and victims of disaster. And this is currently ongoing now, cash transfer program, a project that is run by the Ministry of Humanitarian Affairs in Nigeria through the NCTO, National Cash Transfer Office, and what we have not seen is we have asked for the impact evaluation to be done, so that in terms of evaluation, it is also, I just try to put this because this is what it's called in Nigeria, household uplifting program, and it's done conditionally. In terms of conditionally means you have to meet some conditions for you to be able to access the cash. And it's operated, like I said, by the Federal Ministry of Humanitarian Affairs, and it enhances improving. I included this last, that we need to improve targeting of beneficiaries in order to avoid wastage, where we have civil societies and communities as monitors. That is critical. Use of conditions that will stimulate participation in ANC attendance and delivery. I repeat, delivery in health facilities. Strengthening nutrition goals, optimizing and empowering women through improved access to resources. I just needed to, you can read this later. Oh, okay, good. Mrs. Gabriel will be happy. I've almost concluded it now. Now, in concluding, these nutrients, energy, protein, folic acid, iron, calcium, and vitamin B and C, they are important for the pregnant and lactating mothers to prevent morbidity and mortality, and overall help not only the growing fetus, the development of the fetus, but also the mother. The mother needs to be healthy. No woman needs to die bringing another life and bringing another person to life. Many of these specific that we have described earlier, they are cost effective, especially when studies have even shown in Nigeria and 3 other sub-Saharan countries, either as a package or when used singly, using different cost, using modeling effectiveness, and using different scale scenarios, which I think states can adapt depending on the objectives with different delivery. I put different delivery channels in different regions of the country. It doesn't have to, it shouldn't be one size fits all, no. In a similar vein, we have also put nutrition sensitive interventions, especially in the realm of agriculture and poverty reduction strategies, such as social safety nets, can be adapted. We have seen it already is working. When I interacted with the Ministry of Human, I'm told that by the end of this year, they might run out of funds, and the program is a project really, might likely come to an end. But we'll have learned some lessons on how can we take it forward, because it's all over the country. So the 12 states that are present here, I'm sure they can talk about the social safety nets. But I hope what I'm told at the federal level is what is in your state. However, this is where I want us to also targeting and sustenance of these interventions to those who actually need them is critical. When we don't target, we waste resources. It will help us to achieve. And where iron supplementation, I try to give an example. Instead of giving it as a blanket interventions in some parts, except where we have evidence. That's why evidence-led interventions is the best. Where we think that we have early marriages, especially in the arid north and so, it may be necessary. But for the southern Nigeria, where where cost, I'm not saying it's not necessary in those places, please don't get me wrong. Where cost is a challenge, we may decide to also use alongside BCC strategy that can improve consumption of iron-rich foods. These scenarios are necessary, and I'm sure we will be able to get them implemented. And there are compelling evidence, like I said, for policymakers, political and thought leaders to make decisions. Finally, if you go back to that figure 1 as I round up, Nigeria should not be in that with Somalia, Democratic Republic of Congo, and Afghanistan. Some of these, at least Somalia has no central government. They should not be better than Nigeria. So our policymakers need to take action with our advocacy, because I've been hearing a lot of about advocacy, and advocacy that wins so that we can make a difference. I'd like to stop here because I'm given just 15 or 20 minutes to make a presentation. Thank you. Thank you, Mrs. Gabriel. I'm done.
Thank you so very much, Dr. Sylvester. Honestly, you've done a great justice to this subject. We're indeed highly pleased. And in actual fact, if you could see the whole hall, everyone is, focused and highly attentive. We thank you so much for that brilliant presentation. But we will be having questions that you would need to respond to. However, thank you so much, Dr. Sylvester.
Thank you too.
In summary, I think we need to begin to get worried. At this point in time, I am worried. I'm really worried for us as a nation, for our children, for where we are. And when I saw all those gory, indices, it tells about what really the situation is. And for us to be comparing MMR with that of Somalia, I think it's a big shame. It's a big shame on us all. It's a big shame. We need to be alert. We need to do something. I think I'm looking forward to the day whereby everyone will be called on board. We'll all just sit down and say, how do we actually move forward? How do we move forward? It's not enough to start putting up, things on board. How do we, as a nation, move forward? I think these are heart, rendering questions or things that we need to begin to address inwardly, even as individuals. On that, he also well, let me quickly move away from that before. He also talked about nutrition-specific interventions, targeting the immediate causes of undernutrition, that is inadequate dietary intake and ill health. While nutrition-sensitive influence the underlying determinants of nutrition. Of course, we all know that nutrition-specific is the underlying determinant of nutrition. We also talked about the fact that given what we know about the work done already on proven intervention, there is need to select nutrition-specific and sensitive, and nutrition-sensitive interventions that will impact on childhood stunting
Also impact on pregnancy and lactation, thereby improve maternal health and nutrition. I think that in summary is what we were able to capture. It's a lengthy presentation. We talked about investing in nutrition and what the benefits are, And I'm sure most of us here are very conversant with the benefits of investing in nutrition. Now, shall we have, are there, well, to our highly esteemed viewers online, I want to say thank you. You can now join us in the question and response period. Do you have questions online? Are there questions from our online viewers? Now, questions here that he needs to respond to before he leaves. We just have 5 to 7 minutes for questions. Is it that we are so satisfied with that presentation, or some of us were probably sleeping? Because I was so engrossed in it. Oh, it's so brilliantly presented that we understand all. Any question?
Dr. Motola is raising up his hand.
Because I think that's the core of our service delivery interventions. Yes, please. Okay, I can sorry, I can see 2 hands.
Good afternoon.
Good
Thank you,
afternoon.
sir, for that wonderful presentation. It was very educative, actually. My question is that, which are the most significant supply and demand side barriers to achieving optimal maternal nutrition during pregnancy and lactation? And how can we achieve this?
Question again, please. Can you come again? I didn't hear it very well.
The most significant supply and demand side barriers that will be used to achieve optimal maternal nutrition during pregnancy and lactation. How do you balance the supply and demand? How can we address this issue so that
balance demand and supply? Oh my God, I didn't hear this.
Dr. Sylvester, I think you take all the questions and then you react to them. Yes.
Okay, thank you, Dr. Sylvester, for the presentation. My question would be in regard of the food fortification. In the presentation, you mentioned oil, flour, I don't know what there's anything. Sugar, but there was no mention of rice. And I know in Nigeria—
No mention of?
Rice
Okay.
Yes, and I know in Nigeria, you presented that over 90% of people consume sugar, but we have that percentage is just as high for rice in Nigeria. When we also know that each Nigerian, in average, consumes 77 grams per day, which is the benchmark for regulation in the country where you can potentially move toward rice fortification. So I would like to know, what is your thought on rice fortification in Nigeria and how that would help move the ball on not only stunting, but as well as micronutrient deficiency? Over.
Okay.
Dr. Sylvester, can you please respond to those 2 questions?
Okay, good. Let me begin with your comment that how do we move forward using the, I dare say that yes, we'll move forward on this with the lessons that we have learned in the past, the lesson that we are currently learning with the ANRiN program, because there are lessons as we implement. There are lessons that we are learning, and how can we put all these lessons together and use it in non-ANRiN LGAs so that we can have a whole, for example, in a particular local government. And at the end of the day, we have many LGAs that are looking like the ANRiN. And that is how to move forward. When we learn from our mistakes, when we learn from our successes, we can put all together and move on as a state and as a country. So that's my just comment on that, your earlier comment. The first question was, it's still a little bit unclear to me, but you know, what I had was demand and supply. I thought whether the was asking questions on barriers or intervention. So I didn't get that question, even though she repeated it again. I'm so sorry, I didn't hear very well. But the second one on, so I can still interact with if the lady who asked that question will be kind enough to put it on the chat box. I can respond to it even before the end of the day, or if not immediately, for the end of the day. The second one, the mentioning rice fortification. I know that, you know, during the processing of rice, especially during the polishing, vitamin B, vitamins, some of them are lost. I don't even know the other one, but I know that B vitamins are lost. And so I don't know, one, I must confess this, whether there is a mandatory fortification for rice in Nigeria. The ones I know of was the ones I stated, and I quoted TechnoServe. And I also I know that there was a report after that, but I don't know much about rice fortification. But the little I know about rice fortification, I know that during processing you lose some vitamins. I don't know if there is, what the lady is asking is whether that fortification is mandatory. I would like to if it is not mandatory, it means then that you can provide, I mean, you can produce your rice, package it, and still sell, so long as it meets other criteria of NAFDAC. But if it is mandatory, I would like to get more information. I hope my responses were useful. Hello.
Thank you very much, Dr. Sylvester.
Please, for the first presenter, I would like her to still put it on the chat box, because I didn't understand, so I can respond. Thank you.
Sorry, we didn't hear
the first person lady, well, both of them are ladies anyway. The first lady who asked a question, can she kindly put it in the chat box so I could read it and respond? Because I didn't understand what she wrote, or what she said, rather.
Okay, I think she will private chat to you later.
Okay, I'm grateful for that.
Yeah.
Which are the most significant supply and demand side barriers to achieving? Okay, I've seen.
It's already there, sir. It's already there, Dr. Sylvester.
Okay, listen. Which are the most significant supply and demand side barriers? Optimal.
Okay, on that note, honestly, we want to say very big thank you to Dr. Sylvester. We will continue later on with you. We are not the individual or any one of us that wants to go. But however, I think it would be nice for us to have this presentation, you know.
Okay, it's already with the organizers.
Okay, thank you.
They only allowed me to use my screen.
Thank
to
you,
share my screen.
Thank you, we appreciate it.
Side barriers.
Nice day. And thanks for joining us.
Thank you for.
On that note, another round of applause for Dr. Sylvester. Now we have with us a distinguished guest who is here to represent the Director of Family Health. He is going to be the moderator for the panel symposium, increasing uptake of nutrition sensitive and specific ANC services. I have the pleasure to invite Dr. Kamal Shoretire, okay, Head Inspectorate Division, FMOH, former National Manager, ANRiN, representing Dr. Salma Anas. Oh, great. You're most welcome, sir. Welcome. You want to have the pleasure of calling your panelists to
Good afternoon, ladies and gentlemen. Once again, this is Camille Shoretire, standing in for Dr. Salma Anas Kolo, the Director of Family Health and the Supervising Director for the ANRiN project at the Federal Ministry of Health. Our panel symposium for this afternoon, apologies to all our attendees of this conference and those that join us online, that we are 2 hours behind schedule. The symposium is on increasing uptake of nutrition sensitive and nutrition, increasing uptake of nutrition sensitive and specific ANC services. There are 3 panelists that will be doing justice to this. They are panelists of tremendous experience. The first speaker, the first panelist is Dr. Titilola Abolade. Perhaps we should project, okay. She is a program director for Nutrition International in Nigeria. She has several years of experience in nutrition programming and our areas of she's worked over these years in areas of maternal and child health and nutrition, adolescent and young people's reproductive health, family planning, promotion, and advocacy. She's also worked in the areas of eye health, education, and neglected tropical diseases control. She is passionate about improving the health of the vulnerable groups, including women and children. So Dr. Titilola Abolade will discuss our experience on the nutrition leverage and influence for transformation, integrating nutrition interventions into existing and large-scale platforms that are reaching target populations through service delivery and other means of engagement. She's currently the Program Director, Nutrition International. I hope she is online. Please let us appreciate her and welcome her to the panel. The second panelist is Bulus Sani Shabanda. Let's project him. He will be sharing experience from the ACF cash transfer program experience in increasing the attendance, okay? Increasing attendance to nutrition and health services in Jigawa and Borno states of Nigeria. Bulus Sani Shabanda is a public health expert and community development programmer with almost a decade experience working in conflict areas, as we've mentioned, and is currently the Deputy Head of Nutrition and Health Department with, can I say, Action Against Hunger International, the mission in Nigeria. Previously, he's consulted with UNICEF and on several activities. He's a certified acute nutrition analyst and has a master's degree from the Miriam Abacha University, Niger Republic. Distinguished ladies and gentlemen, Bulu Sani Shabanda is one of our panelists today, and we share this experience on how we can increase uptake of nutrition sensitive and specific ANC services through the various projects and activities he's been involved in. Please welcome Bulu Sani Shabanda to this panel. Thank you. Our third panelist is Darlene Raphael. Darlene Raphael has worked on multi-sector malnutrition prevention projects. She's currently the head of nutrition of the World Food Program Nigerian office. She has almost 15 years experience working as a nutritionist. She has a degree, master's degree in nutrition from the University of Montreal. She's worked in Niger Republic, South Sudan, before coming to Nigeria. And her area of coverage as a director of programs include nutrition and school feeding in these conflict-affected areas. And now she's in Nigeria, working in this mission office of the World Food Program. She'll be sharing her experience in this panel. Let me also know that she speaks several languages, including French, Creole, and English. Welcome, Darlene Raphael, to this panel. Thank you very much. So I hope the three of them are in the panel room. Can I hear their voices? Are they online?
Yes, Dr. Camille, I'm here.
Darlene is here physically. Oh, thank you. So each panelist will be speaking for 5 minutes. And after we've listened to the three panelists, we'll have about 10 minutes for the question and answers and discussion. Okay. So once again, a round of applause for these panelists as they entertain us with their expertise. Thank you very much. So I will start with Dr. Titilola Abolade. You are welcome, ma'am. You have 5 minutes. Thank you.
Thank you very much. I'll just share my screen. Can you hear me?
Yeah, yes, we can. Go on.
Okay, so I'll go ahead to share my screen right now. Can you see my screen now?
Yes, we can see it.
Okay, I want to thank everyone. I want to say big congratulations to all stakeholders and esteemed participants at this meeting. And I bring you greetings from Nutrition International. I'll be speaking on the topic, integrating nutrition interventions into existing large-scale platforms that have potential to reach a large audience, and using the Nutrition Leverage and Influence for Transformation project of Nutrition International as a case study. Okay, just a bit of a background about Nutrition International. We're a global nutrition organization since 1992. We were formerly the Micronutrient Initiative, and for over 25 years, we've worked with an array of stakeholders to promote and accelerate and facilitate the scale-up of high-impact nutrition interventions within health, food, and education systems. And you can see there from the map where we work, mainly in Africa and in Asia. So I go on straight into the outline of my presentation this afternoon. We'll provide a bit of an introduction. I know other speakers, including Dr. Sylvester, have laid a very solid background around the maternal health landscape in Nigeria and nutrition landscape in general, and why urgent action is needed. Then I'll tell a bit of a story around the ANRiN project, and also and give you an overview of the ANRiN project in Nigeria, as well as the strategies used, the results, challenges, and some lessons that we learned on that. So just to also add to what others have said, globally, we know iron deficiency is the most common cause of anemia during pregnancy, and it's a major cause of perinatal and maternal mortality and morbidity. Actually, because iron requirements double during pregnancy, there's a need for pregnant women to have added supplements, and that is the iron and folic acid supplements to prevent anemia, because due to a number of reasons, it's really difficult for pregnant women to get all the iron that they need every day from the food that they eat alone. And so it's recommended in pregnancy and has been proven to reduce risk of anemia at term by 70% if pregnant women take iron and folic acid supplements as they should during pregnancy. Malnutrition before and during pregnancy can lead to low birth weight babies, and which also increase risk for stunting and maternal and neonatal mortality. Low birth weight is actually the leading cause of infant death in the first week of life, while those who survive often suffer from a range of health issues. And we know how anemia also impacts on health and economic productivity. For Nigeria, we know anemia, especially among pregnant women and women of reproductive age in general, is a severe public health problem. We have it at 58% among women of reproductive age and at 61% among pregnant women from the NDHS 2018. Now, looking at the intervention, like how many of these women actually take iron and folic acid supplements during pregnancy? The NDHS shows that only 31% of women actually took iron tablets daily for 90 days or more, whereas about 31% did not take at all. And knowing how important this is in pregnancy and the fact that sometimes there are inadequate access to these health commodities and essential medicines, including the iron and folic acid, which has proven to be an essential control and prevention measures to reduce anemia. There's a need to act fast to ensure that we improve the health of our women and also improve pregnancy outcome as well. We have really low, bad indices around maternal mortality rate in Nigeria. So off to the ANRiN project. Now, when we say ANRiN is an acronym that means Nutrition, Leverage, and Influence for Transformation. It's actually a pioneering initiative of Nutrition International. We received funding from the government of Canada to carry this out. And ANRiN uses innovative strategies. It looks at cross-sector partnerships to integrate nutrition interventions into a multitude of development platforms, which otherwise would not have included nutrition, and pilot new approaches to scale. And the reason for this is because we feel that by expanding opportunities for nutrition impact, we will be able to, through ANRiN, accelerate progress towards the global nutrition targets through improved nutritional status, especially for women and adolescent girls. Just to put a bit of definition into some of the key words in the ANRiN, when we talk about leverage at Nutrition International, we're looking at integrating nutrition across sectors, strengthening local ownership, and also developing innovative approaches to scale. In influencing, we want to combine research, technical assistance, advocacy, and partnerships to improve policies, programs, and to increase resources for nutrition. So how did we envision the change through the ANRiN project? Now, we identified that there are existing platforms, programs, and networks that are already reaching the target group that we're interested in, especially women and children and adolescent girls. And so we look at it as starting from the point of using those existing platforms and programs and networks, leveraging resources from them, and then reaching women and adolescent girls and other vulnerable groups with life-saving interventions towards improving their health and their nutrition outcomes. And invariably, contributing to improving their economic future. Now, while we're doing this, we believe that missed opportunities will be reduced, knowing there are lots of programs ongoing, reaching this same target group, and that could also be we could also use that opportunity to also reach them with nutrition services. And thereby, when we do this, reduce missed opportunities, we're also effectively expanding the reach of effective nutrition interventions. From Dr. Sylvester's very detailed presentation, we could see how important these interventions are, and they are among the interventions that are really actually very cost effective, like the iron and folic acid supplementation. So an overview of the ANRiN project in Nigeria. So we actually started the ANRiN project in Nigeria in June of 2018, and it ran up until last month, March 2021. It's actually a partnership between Nutrition International and UNFPA Nigeria, because we believe that lack of access to sexual and reproductive health services can have a significant impact on nutritional status and overall health of women and girls. And this can even compound health issues. And so we feel that by joining forces with UNFPA in Nigeria, we can leverage resources, we can leverage our expertise and platforms as well, and even existing relationships and collaborations to be able to reach the most vulnerable population for nutrition as well. They are currently being reached, they were being reached with sexual and reproductive health services that UNFPA focuses on. And so it was, on our part, we felt it was a very great opportunity to join forces with that type of organization, to also use the same platform to reach women and adolescent girls with nutrition services. And we feel when we do it this way, it's a win-win for both organizations, because the collaboration in project design, in implementation, in monitoring and evaluation will also support UNFPA towards achieving its own transformative goals of ending preventable maternal deaths and gender-based violence and the rest of them, while also we are also contributing to reaching more women and adolescent girls with nutrition services. So in terms of integration, the project integrated and leveraged on existing UNFPA sexual and reproductive health initiatives. And those initiatives are listed below. The first one was a 3-year project that addressed sexual and gender-based violence and harmful traditional practices, and actually targeting adolescent girls. The second one is the National Mandatory Continuous Professional Development Program for nurses and midwives.
Dr. Abolade,
yes.
We have 1 minute more. Can you quickly rush through, please?
Okay, I'll quickly rush through my presentation, please. And the third one is the family planning, reproductive health services generally in government health facilities that are supported by UNFPA. And this is the overall objective of the partnership, was to improve capacity of health service providers and increase knowledge and awareness about nutrition, anemia, and healthy eating for women of reproductive age and marginalized populations, including adolescent girls and their influencers. The geographies for the project are as follows. At national level, the maternal nutrition model for nurses and midwives actually covered all the 37 states of the country, while the adolescent program was targeted in Sokoto, Gombe, and Bauchi State, where UNFPA currently had that program. And also in Kaduna State, we had the nutrition counseling in health facilities, and also the mapping of supply chain for iron and folic acid. In terms of key strategies that we employed in implementation, I've talked about partnerships and collaboration between NI and UNFPA, and also national and state level partners, Federal Ministry of Health, Federal Ministry of Women Affairs, Federal Ministry of Education, Nursing and Midwifery Council of Nigeria, and the rest of them. There was also the integration into existing SRH platform. Advocacy was also key, and the technical assistance, knowing that UNFPA is not a traditional nutrition delivery organization, and so there was a need for adequate technical assistance provided to be able to deliver the program. Also, we had participatory curriculum development, capacity building for health service providers at different levels, and also service delivery, monitoring and supportive supervision, behavioral change communication for communities and influencers, and also supply chain assessment around iron and folic acid iron and folic acid supply to actually find out what are the bottlenecks that are causing stock out in health facilities and the rest of them. In terms of results, these are the project's final evaluation has been conducted and the report is being finalized at this time. So I don't have the result from the final evaluation, but these are some program level data that we were able to retrieve last year on the program. And looking at the key result areas, most of the result areas actually exceeded their target. Only the midwives training via the MCPDP wasn't able to achieve our target, mainly due to movement restrictions because of lockdown as a result of COVID last year. But we are happy to let you know that the platform is always there. It's a set platform, and we expect that more nurses and midwives will uptake the maternal nutrition module that was specifically developed and placed on the platform for continuing medical education for nurses and midwives in Nigeria. In terms of successes, we would say that integrating nutrition into the nurses training via the mandatory continuing professional development program actually will have a lasting positive health and nutrition impact way beyond this project. The project has ended because the platform still remains and it covers the entire country. We believe that maternal nutrition counseling was also successful using other platforms, and ANC clinics, family planning clinics, postnatal clinics to reach women with nutrition information. Also youth-friendly nutrition module developed to reach adolescent girls through the Girls Safe Space initiative. And we believe that the nutrition, sexual and reproductive health messages that were delivered to community members through radio talk shows were also beneficial, as well as the partnership between Nutrition International and UNFPA provided us an opportunity to actually reach more girls and women who otherwise might not have been reached with nutrition intervention.
Thank you very much, Dr. Abolade. Please let us appreciate her.
Let me just conclude, please. The ANRiN project actually demonstrated valuable lessons on how sexual and reproductive health platforms can be leveraged to avoid vertical delivery of life-saving intervention. So the message today is that
Abolade, please don't worry. We can read it. We can read it.
All right, thank you. Thank you very
so
much for listening. So let's act
let us
together,
appreciate
innovate
her.
and integrate. Yeah, thank you.
I'm delighted to know that where the ANRiN project took place, at least two of them are ANRiN states, Gombe and Kaduna. Thank you once again. So let's move to the next. Please, let's take note of our questions while we take the next speaker, and that is Mr. Bulu Sani Shabanda. Can we have him? Projected. Is he? Please, the next speaker, please. Oh, you're the one. Okay. Let's share the screen, please.
Thank you so much for giving me the opportunity, and good afternoon, ladies and gentlemen. And I'm standing on the already existing protocol. I have the honor to represent Action Against Hunger to share with you some of the experience we have in implementing projects that improve cash transfer program that improve outcome of nutrition and health services in two states, Jigawa State and Borno State, Nigeria. Next slide. So as we know, as a result of conflict that have been ongoing for over 10 years, Borno State had over almost 1.6 million internally displaced people, and 75% of those population living in the state are in the need of humanitarian assistance. This information is coming from the humanitarian need overview of 2020. So most of the IDPs living in either internally displaced camp or host communities greatly rely on humanitarian assistance to survive and improve their living condition. So, and rate of malnutrition in Borno State, which is aggravated mostly because of the conflict, have worsened since 2018. We have about 33.1% of stunting rate in the state, and gum prevalence of 10% in the state. While if you compare with what we have in 2019, gum rate is about 9.1%. And it is worth to note that in Borno State, we have about 5% of IDPs that don't have access to primary health care within 1 hour distance walk. This information is from the Humanitarian Need Overview of 2021. In Jigawa State, the rate of malnutrition is worrisome. We have about 2 million children, which equate to about 54.1% under 5 children that are stunted based on the NNHS 2018 report. And with regard to wasting, the Jigawa State have about 12.5% of acute malnutrition, GAM, and then SAM is about 1.6%, which is alarming indicators. And looking at the rate of ANC attendance, most women in the states have no contact for ANC. About 1 in 4 women who had live birth based on the analysis had made no antenatal care visit. So as a result of this high or alarming rate of indicators, Action Against Hunger in collaboration with relevant government agency design and implement 2 projects, namely the CDGP program, which is Child Development Grant in Jigawa State, and Forage Mom program in Borno State. Child Development program is funded by FCDO, formerly known as DFID. It's a 6 years development program implemented in Jigawa State. The program generated an outstanding outcome with transfer relatively very low. The transfer rate is meeting about 25% of minimum expenditure basket. We are targeting pregnant and lactating women, looking at first 1,000 days of life. Initially, we are transferring, we are sending 3,500 naira to these women, and later we increased to around 4,000 naira monthly transfer. We did this transfer for about 33 months. The targeted we reach is about 93,000 pregnant women over the period of these 6 years. The transfer process or the conditionality of this program is we implement, in addition to this cash transfer, we implement 2 types of social and behavioral change activities. One, we have a low intensity program which focus on the posters, text message, radio, discussion, health talk, and then food demonstration. And as well as we also implement high intensity, which focus on the support group, one-on-one counseling, and in addition to the social, cash transfer we are providing to this set of women. And also in Borno State, as I mentioned earlier, Forage Mom program, it has been ongoing since 2016 with funding from USAID, currently now BHA. Action Against Hunger select and register most vulnerable household in the targeted LGAs and state of Borno and Yobe State. Where we have group of women that come together to discuss and then cook together, and then they receive messages related to maternal, infant, and young child feeding practices. So in this Forage Mom program, each Forage Mom beneficiary receive a token of 5,000 cash transfer that is sent through voucher, and then the amount is restricted only for food commodity that is related or associated to the group cooking activities. And at the end, each of these women contribute food worth of 4,000 naira for cooking activities. And then she redeemed 1,000 naira worth of food and take home to practice what she learned in the Forage Mom kitchen. This is this. Next slide. Yeah, these are some of the pictures. Next slide. Okay. Yeah. So for the CDGP program, when we try to check beneficiaries of the porridge mom, we look at the baseline data we have and the end line data we have. We discover about 55% of pregnant women have attended antenatal care in the areas we implement, compared to 45% during the baseline we have. And then when we try to check women and ask them question on do they think it is best to start breastfeeding immediately after birth or within 30 minutes of giving birth? About 69% of them said yes, they think it's best to start breastfeeding immediately after birth or within 30 minutes of giving birth. When we compare to non-CDGP implementing area, we discover only 42% of them think it's best to start breastfeeding immediately after birth. And then the rate of children who consume food from one or more group were about 51%. So rate of exclusive breastfeeding increased to about 70%. Right, so for porridge mom also, proportion of infants 0 to 5 months who are exclusively breastfeeds increased to about 90%. Right, so some of the successes we had. Next slide, please. Some of the successes we have is the project has helped address the basic food need of the vulnerable population and also improve the behaviors and uptake of health services. As I mentioned, most of them increase the rollout in the ANC, hospital delivery, and a lot of other things. It also impacts health services. On the challenges, no program is, will be implemented without encountering challenges. We encounter some of the challenges which include in Borno State specifically the NSANC, non-state armed groups, putting checkpoints. So our vendors that are bringing food to this porridge mom beneficiary are not able to move food. We encounter daily inflation of food items, and then sometimes the beneficiary are at the meat of receiving this benefit, but they move to other places that they
Thank you, Bolus. Yeah. Thank you very much. That's a good one to.
Next slide. Yeah, so some of the lessons we learned, yes, I'm rounding up. Yeah, some of the lessons we learned is cash transfer program is most effective when complemented with nutrition specific and nutrition sensitive intervention. Mostly when you implement cash transfer program alone, is not sufficient to impact the nutrition outcome. Thank you so much.
All right. Thank you very much. Please let us appreciate him. A nice implementation in Jigawa and Borno, and we've seen lessons learned, increased utilization of ANC services. Thank you. I would like, please let's reserve our questions, and we'll go to our third panelist, Darlene Raphael. She's here with us. You're welcome once again.
Okay, thank you.
All right.
I think I'd rather stand up than give you my back while I'm talking to you.
Okay.
So I think that would be best. If they could project the few slides that I've shared with the organizers. Yeah. So maybe just quickly to start, I think these maybe panels fit well with what Dr. Sylvester was presenting this afternoon, because we are basically presenting you practical or experiences on how you can actually design projects, implement them to prevent stunting and malnutrition overall. So the presentation this afternoon is a multi-sectoral project that was implemented by partners through the World Food Program. It was a part of a consortium that was implemented by 3 partners, UNICEF, the World Food Program, and ACF in both Borno and Yobe State. But the multi-sectoral component that I'm presenting this afternoon, that was under the responsibility of the World Food Program, was implemented solely in Borno State. And that project, as we have been talking this afternoon, was not only focusing on nutrition specific, but as well as nutrition sensitive interventions. Next slide, please. So I think this is just to say we were implementing in Borno State, and we had 3 partners. You can see them maybe on the other side. IMC, Plan International, CAID were responsible for the implementation of the project. Next slide, please. So what was the aim of this project? As you say, we have been talking a lot about pregnant and lactating women. We have seen the requirements. We have also seen the consequences of when we have poor nutrition during that period of life, the window of opportunity for children. We are talking about the brain development of the children. And as we might know already in the room, children under 2, if they are malnourished during that period, the consequences we meet with them for the rest of their life, particularly the development of their brains. So therefore, we are focusing on the 1,000-day window of opportunity. There was also an aim to increase demand of mothers and family to take up more of the basic health services, ANC, PNC, SAM treatment, micronutrient supplementation, immunization. We wanted to increase awareness, or IYCF, to enhance SBCC. I will explain that later what enhanced SBCC was, but also empower families, particularly women and girls, to improve their nutrition through locally available nutritious food. So find those food that are available in country and be able to use it. But lastly, we wanted to elevate the priority of those type of project when you have integration between nutrition sensitive, nutrition specific, not only at state level, but as well as federal levels. Next slide, please. So the outcome of the project, what we were aiming at, to improve consumption of high quality, nutrient-dense food among the target beneficiaries. So basically wanted to improve not only stunting, but all form of malnutrition. The indicators that were used, we were looking at minimum acceptable diet, looking at the consumption among children, the quality of the consumption among children 6 to 23 months, as well as looking at the percent that reached the minimum dietary diversity among women. And we wanted also to see whether those beneficiaries were acquiring any new behaviors in terms of the nutrition messages that were passing as well. So the target group, we weren't gonna spend much time on that. They were the children, 6 to 23 months, and the pregnant and lactating women. Just to mention that and we'll talk about that before, we use the SCOPE platform where the identification of the beneficiaries are done through fingerprints. Next slide, please. Beneficiary selection criteria, maybe just a few words on that. As you know, it's a project. We want to target the most vulnerable. So how do you do that? So you have to set up some eligibility criteria are quite obvious and evident because these are the children 6 to 23 months pregnant and lactating women. But when you talk to, once I have those households, within the community, who do I pick? This is where we come up with the vulnerability criteria, where you have to put together a set of criteria to say who are the most vulnerable within those communities. So those households are the ones who will be benefiting from those programs. Next slide. So the first, now looking at the actual activities that were implemented, first we had a cash transfer mobile money that was transferred to the caregivers of the children or the pregnant and lactating women. The amount of 5,000 were transferred on a monthly basis. And here, like we said, this is additional resources to ensure that those target groups had actually could improve their nutrition during that period of life we already mentioned. And then just quick numbers, because I put the result throughout. The project will reach over 21,000 women with the cash transfer mobile money approach. Next slide. Livelihood. So this is where you say, on top of the nutrition specific intervention, livelihood, making sure to of the nutrition-specific intervention. For example, for a period of 1 year, you provide cash assistance to women to provide nutritious food for their children or for themselves. So, and then you train them on what to eat, how to eat. You provide social behavior change communication messages. And then after the period of the project, it just ends. Or you remember we had targeted the most vulnerable people in the community. So how are they going to continue with all those good behaviors that you have informed them on? So this is why we come up with the additional component of livelihood support, where we were providing income generating activities specifically for women, as well as village savings loans and association, where the project was providing startup money for the women to come together in association so they could start businesses as well as and some small businesses and have some savings. So the objective was to empower women and girls to ensure sustain. This is where we come to the sustainability component, so they can continue beyond the life cycle of the project with the right approach in terms of a nutritious diet. Next slide, please. So social behavior change communication environment, just to say, while we're doing the social behavior change communication, promoting the message on IYCF, but what is relevant here is that this by done what we say mobile. So the participant of the project, they could receive those messages to their mobile phones to ensure that they have access to the message, not only doing the activities that are done at community level, but as well as direct messaging that is done to them. And the health workers on the project as well, they could download those information and play some jingles doing the mother-to-mother support group at community level to support those type of activities through that platform that we call mobile vulnerable analysis. Next slide, please. Capacity strengthening. Of course, there was a component of capacity strengthening where the objective was to engage all the relevant stakeholders to come together, whether beneficiaries, communities, community nutrition mobilizers, the health facility staff, not only on training, on the specific thematic of the project, but as well in terms of coordination. Actually, it was a consortium, so you had other partners on board, but we wanted as well to bring the authorities at LGA level, state level, as well as not federal level, no, we didn't involve federal level, but state level and LGA levels. Next slide, please. So the lessons learned, because I think this is a practical example, and I think anyone who would like to build on this experience, I think for me, these were the slides that I wanted to put the more focus on, so we will know how do we best use and improve those type of programs. Lessons learned. The first thing is this was a project that was implemented for a period of 1 year. So the lessons learned is when you're targeting the 1,000 days window of opportunity, the best scenario is to have a multi-year project, minimum 3 years, 3 to 5 years, if you want to see real impact when we are talking about the stunting level. Because right now for that project that was 1 year, I can give you improvement on dietary diversity, on minimum acceptable diet, but it would be very difficult to show any significant change when it comes to stunting because of the duration of the project. Well, it was important to have a community-based approach. I think Dr. Sylvester mentioned that in his presentation, the targeting. How do you target? Because I'm in a community, I want to target the most vulnerable. How do I ensure that the community actually accept that I pick this person and not this person? So this is where you have to bring the community on board, the leaders, then all the influential people from the community to ensure the registration enrollment is well understood by everybody. So I don't know whether there's anything else that of relevance to mention as the time is running by. Mobile money. There are some, when you are in rural areas, there are some challenges when it comes to transferring cash, particularly access to connectivity issues. So next slide, please. Sustainability, we already mentioned that. I think for me, the point that came more as a highlight for this project is beyond the project. If you were to go in those locations, some women, they still have those small businesses and those small groups where they are putting savings together, they still have those. So because those groups were put together, they had some savings. Some groups were able to save as high as 9,000 US dollars, women groups. So because those activities are already there, even at the end of the project, they will still continue with them beyond the life of the project. So you could say that multi-sectoral project cost effectively establish a sustainable community-based financing support system for this community. And the last slide,
Thank
please,
you, thank you.
Takeaway.
Okay, takeaway is what?
But I want to say this. What should we take away from this? The takeaway from this, it's not the project itself. The takeaway is there are model that they are as good example on how to design a safety net, nutrition safety net program for the country. When we are designing those type of program, think of the vulnerable group, under 2, under 5, pregnant and lactating women. Why doing so? What do you do? First, you're looking at income inequality. You're looking at the same time at women empowerment while making at the same time impact on child and maternal nutrition. So I think this is worth it. Just to finish, I'm new in Nigeria.
Okay.
I just arrived here,
Just round
but
up,
I met
okay.
with the director of nutrition, and I told her my dream is to see a national stunting prevention program in Nigeria in the next 2 years. Over.
Thank you, thank you, thank you. And we've started with the ANRiN project. So let us appreciate all our panelists. Because we've not been able to keep to 5 minutes per presentation, the Q&A sessions we have to reduce from 10 minutes to 6-7 minutes. Thank you. So the questions for Dr. Titi Abolade, I think we can send in chats or let us have it and we quickly give all the questions. And then the one for Bulus Sani Shabanda is physically present here and Darlene is also here. So they can listen to the questions and so can we have a show of hands or do we have from our online participants? Are there questions in the chat box? Let us know how many. 1, 2, 3. And
hello, my name is Elebo Caroline from Abia State, M&E. My question goes to Dr. Titilai. I want to know the reason why is it that is 31% of women access this folic acid, and how you people will ensure that those people that collected the folic will take it. Thank you.
Thank you for the presentation. Well, for Mr. Bulusani that is here, my question is that the ACF was for 6 years. In terms of sustainability, what will happen after 6 years? Is it that you have something with the state government like Jigawa or Borno that will continue what you have done? Because it seems, I have an idea that if you keep giving out money and then how sustainable that would be, that's one. And then I don't know, but I have this fear that there's some form of bias, maybe because there's conflict, that the vulnerable groups we are giving, do they really have option, or is because of the situation that they are actually accessing service? I want us to look inwards into that. Then for Dr. Titilai Abolade, that my question is, how will you use the already existing platforms, because that's one of the things said, especially in regards to this ANRiN, so that it will not be like where one project will come, do something, another project will come and still keep doing the same thing. Thank you.
Okay. I have 2 questions, one for Titilola and one for Mr. Bulus. The one for Titilola is, she said the project started from June 2018 to March 2021. So we all know that projects come and go. The essence of project is meant to strengthen the system. But can she tell us what are some of the plans she has on ground, or the project has on ground, to ensure sustainability after the lifespan of the project? Just like she said, the project was technically over last month. Then for Mr. Bulus, he said that the project was implemented in 2 states, Jigawa and Borno. So I believe that in order to make informed decisions, it is better to have more states, because different states have different challenges, so which will require a different approach. So in doing that, do they have a plan to scale up to other states so that at least they will have an elaborate number of states which will help in making decisions? Thank you.
Thank you for those questions. Shola Oresonya has a question for Dr. Abolade, and it goes thus. Have you thought about also leveraging on malaria control interventions, targeting under 5 children, being delivered in campaign models as a means of delivering micronutrients to the same target population? That is a question for Dr. Abolade. We will go to each of the panelists to use 1 to 2 minutes to answer the questions related to them. And immediately we will move into breakout sessions. There's also one more question from online participant, I guess. Action Against Hunger International. What criteria were used in selecting or defining vulnerable households in Borno State, considering the fact that half of the state's population are now in IDP camps? I'm not too sure that is entirely correct, half of the population. But that is a question for Bulus to address. Thank you. So immediately after we listen to the responses, we go into breakout sessions. So do we take, let me take our people in a reverse order. Let's take air from Darling, Raphael. Any question for you? No. Okay, Bulus. Then we'll come back to Dr. Abolade.
Okay, thank you so much for the questions. I'll start with the first question, who is asking about the sustainability of the CDGP project, that is 6 years project after the program ended. So in fact, there are a lot of sustainability plan on ground. I can tell you that Jigawa State government have committed about 2.1 billion naira to establish a national social safety net program. And just to mention that Jigawa State, as it stands now, is one of the advanced states in terms of implementing national social safety net in the country. And currently, the program have ended, but we received a bit of extension. Now, Action Against Hunger is no longer implementing the project, but it's playing kind of advisory role to Jigawa State government in ensuring smooth implementation or smooth onboarding of the National Social Safety Net program they have. And also, Jigawa State have their own initiative with they learn from this CDGP program. They call it Masaki Nutrition Initiative. And on this Masaki Nutrition Initiative project, they donated about 90 million naira that I'm aware of, which they channel to ensure that sustainability of this kind of program. And also not just that, there are a lot of unintended positive outcome that we discover. Most of these women, most of these beneficiary women, they form a group, they call it Adashi. They contribute money out of the token we give them. Most of them buy gold, most of them start a mini business because we also train them on some skills, which most of them are still on it. So it's really something that is sustainable. And then we believe with the buy-in or with the commitment of the state government, this kind of achievement will be sustained. Thank you. And the second question is, what criteria do Action Against Hunger use in defining vulnerable households, considering majority or a large population in Borno State are internally displaced persons? I can agree with you that to choose most vulnerable population in the state is difficult. And I can tell you one of the challenge, I mentioned it in one of my slides, selecting this kind of population is arbitrary because almost everyone is in need. And then what you have to do is to go based on your program target. So we try our best. One of the criteria is we look at those internally displaced persons in the areas we targeted. We have a lot of partners implementing almost similar activities in Borno State. So we have partners mapping specific areas where Action Against Hunger is focusing. So we look at those internally displaced persons, cash household, where we provide them the cash or food voucher. And in addition to that, to be a beneficiary of Porridge Mom Group, as I mentioned earlier, you either have to be pregnant or you be lactating or have child that is under 2 years old. We target first 1,000 days of life. So those are some of the criteria we use in selecting the most vulnerable household. And then there's another question that is asking how can we have informed decision? If possible, we can extend to other states in order to have informed decision on the impact of this kind of program. And he's asking ACF plan in extending this kind of approach. I can tell you ACF is working closely with the relevant government agency. And for now, we have offices in Jigawa, we have office in Borno, we have office in Yobe, and we are working closely with the donors and then looking at possibility of extending this type of approaches. So we hope to scale up, and then we hope to have more buy-in of the relevant state government and the legislative to implement.
Thank you very much, Bulus. Let us go to Dr. Abolade. I hope she's with us so that she can respond quickly to those questions sent to her.
Okay.
Thank
Yes,
you.
can you hear me?
Yes, we can. Go on. 2 minutes.
Okay, I'll try to respond to all of the questions within the 2 minutes. The first question was around why only 31% of women and pregnant women actually took iron and folic acid supplement during pregnancy. We all know that there are several sides to this type of issue, and I think it was also briefly mentioned in the question that was posed to Dr. Sylvester earlier on. So we have both supply side and demand side reasons for this. On the supply side, a number of times we experience stock out in health facilities for a number of reasons. There are competing health priorities in the state, and so sometimes the states are unable to procure adequate quantities of these commodities, and so you experience stock out in health facility. At those moments, health service providers might ask the pregnant women to go procure the iron and folic acid supplement from pharmacies, which some, because due to poverty, are unable to, and so they do not buy and use. There are also demand side reasons for this. The woman herself and the significant others around her might not have adequate knowledge about the importance of using iron and folic acid supplements in pregnancy. There are lots of myths and misconceptions. For example, some people believe that when a woman is pregnant and she uses iron and folic acid supplements, the baby will be too big, and at the point of delivery, there could be complications. Of course, we know that all of these myths are not correct. And so there's a need for information, there's a need for behavioral change intervention to address the specific behavioral issues affecting demand and use of commodities such as this. Some experience side effects, and if they had been told at the health facility level how to deal with such side effects, they might want to continue to use it. But so once they see a side effect, probably throwing up after using it, they stop using it entirely. So there are several reasons why women do not use this. You also said, so how can we ensure that women take it? I've already started to talk about that. It's education, education, education. Women need to be aware of the importance of using it and the fact that it helps to improve their pregnancy experience overall and even the outcome itself. Once a woman hears that something will affect her baby, definitely she would want to use. So our messaging has to be strong here to convince women of the need for them to use it. And not only women, we know in our society, the way we are set up, that there are significant others in the environment, also the husband, the mother-in-laws, and every other significant person in the environment also needs to be targeted for specific messaging to increase demand and use of iron and folic acid supplements. The second question is on how will you use existing platforms for delivering nutrition, I guess. So just similar to what we did on the ANRiN project, there are quite a number of viable and potential platforms that we can use to reach target group. I think the first step is,
all right,
we want to reach
Dr.
target
Abolade,
yes,
sorry,
please.
let me pause you here so that we go into the breakout sessions.
Oh, okay.
And we will address more questions and concerns there. So thank
All
you
right.
very much. Please
Thank
let us
you.
appreciate our panelists once again. And standing in for our Director of Family Health, I'd like to appreciate the panelists once again for sharing these great experiences on how we can leverage on what we have, on what they've done in their various projects to improve nutrition sensitive and nutrition specific interventions to increase uptake at the antenatal level. The three speakers, there is a common denominator that I could pick from my hand here: counseling. All the people involved needs to be counseled, women, lactating women and all that. And then cash transfer is helping as it's expected to help everywhere. Free money comes, we will do what is expected. But more importantly is how we are able to integrate this into existing system and for our government at various levels to adopt these best practices and use it to improve the lives of the people. Once again, thank you very much. Thank you to our online audience and those that are present here physically. We'll go into the virtual room sessions and interact more with these panelists and know so much about their experience from the various projects that have been implemented. Thank you so much. And congratulations to the organizers once again. A round of applause for all of us. Thank you.
Thank you so very much, the great moderator. Even at such short notice, you were able to do such a good job on this. To the other panelists, I want to, Dr. Titilola Bolade, Bulusani Shambada, and Darling Raphael, I say a very big thank you to you all. Thank you for your participation. Now, to our esteemed participants online, we want to appreciate you once again and thank you for your participation. We also have online the World Bank Senior Technical Assistants to state. They have been very, very supportive to the project state, and they have been online since yesterday. We indeed appreciate you. Thanks for your patience. Thanks for your participation. Thanks for all your support, both technical and financial. Thank you so much. We indeed appreciate you. I just want to say to the World Bank Senior Technical Assistant, I want to plead right now that you stay on, you bring out your camera so that the LOC team, okay, we have a change. All of them, all the participants, all those online. Oh, wow. Bring out your cameras, please. We want to have a snapshot of all of you online today. Thank you, thank you. Just give us about 2-3 minutes for us to have a proper frame of, because please, turn on your camera or bring it out. If they don't bring it out, if they don't turn it on, so, okay, they're already doing that. Turn on your, okay. Please do that quickly so that we can have a snapshot of you all. Turn on your camera, please, Dr. Cleto said. Or bring it out, anyone. Okay, what's his name? Pharmacist Cletus. They have to wait for the next 2-3 minutes to ensure that everyone is on. Okay. While we are doing that, while that is being done, I just want to quickly announce to us the breakout groups. Yesterday, there were so many people missing out from their breakout groups. You indicated when you were coming in yesterday, your breakout rooms and groups. Yet, a lot of people did not go to their identified rooms. So we're going to call the names of those in the various rooms and the topics, that you're going to look at. Activity. Now, the first room, the room 1, will be discussing nutrition leverage and influence for transformation, integrating nutrition interventions into existing and large-scale platforms that are reaching target populations through service delivery and other means of engagement. That is for room 1. Now, I have here with me the names of those in room 1, and please, you must go there. The venue is Hawthorne Suites by, sorry, room 1 is here in this room. You're going to remain in the hall here, the grand hall. Of Fonime Udokang is number 1. Udokang, sorry. Usman H. Baraya, you're here. Musa Abubakar is here. Dr. Onu is here. Onu is here. The Udwa Koban G. Akpan is here. Amina Adamu is here. Ramatu Musa. Ramatu Musa is here. Where's Ramatu Musa? Okay. Fatima Isaku. Okay, you're here. Muhammad A. Muhammad is here in room 1. Dada, what's the first name? Yeah? Parrot. Oh, that's a lot. Parrot Dada is here. Giwa Munat Beju is here. Adekaje Marion. Oh, Adekeye. Adekeye, you're right. They are right. Adekeye, right? Marion is here. Omolara Oladeji is here. Muhammad Usman is here. We have Murtala Muhammad Inwa is also in room 1. This is room 1. And I've told you what you're going to be doing. Of course, you better start getting ready to move to your group. Room 1, that's the first group. Now, the second breakout, room 2, the second group for this breakout is the ACF Conditional Cash Transfer Program for ANC enrollment and attendance. We have here, where is that room? Is it Niger? Room 2, where are they? Where are they going to be? The boardroom. You're going to boardroom. And you have there Bashir Mekano Abubakar. Where is Bashir Mekano? Abubakar, yes, you are in the boardroom. Room 2, Lydia S. Ishaku. Lydia S. Ishaku. Yes, you are in room 2. Ehimoni, Sefinat, Eunice. Sefinat, Eunice. Where is that? Okay. Again, you. Okay, Sefinat, it's another. You are in room 2. Ehilegba, Caroline. Room 2. Oyebanji Abimbola Esther. Room 2. Salome V. Aya. Room 2. Bulus Sani Shobamda. It's room 2. Musbao Muhammad. Room 2. Where's Musbao Muhammad? Musbao Muhammad. So some of us are missing. Room 2. Alarakpe Khadija. Khadija Alarakpe. She's not here. I know you very well. She's not here. Okay, she's in room 2. Ogunlusi. Bolanriwa, room 2. Paul Ganjan, room 2. Ukwaba Eugene. Ukwaba Eugene, where are you? She did not, she's not here. She went out. She's in room 2, though. So when she comes, please tell her she's in room 2. Eh? She said? Oh, it's a he. Okay, please tell him he's in room 2. Thank you very much, sir. Harry. Okay. Uko. Eshegon, thanks a lot. We appreciate it. Uko. Ijian. Where's Uko? Uko. So many of us. What? Okay. Bello Joseph. Thank you. Abubakar Yahaya. Abubakar Yahaya. Where are you? It's gone. Where is our brother? It's gone. They are around. They are around. Who told you that? So I will hold you responsible. Okay, thank you. Ahmed Muhammad. Ahmed Muhammad. Room 3. Please tell him he's in room 3. Jimonu, oh favor. The what? The lady, the World Food Program. This, that's, yeah. Okay, they won't be around. So we just put them in. But how many people? Right? They are not. Okay, room 3 has been switched over to other. We're going to split you to room 1 and room 2 because the World Food Programs will not be around to. So what we're going to do, I'm going to pick about 4 of you here and then 3 into how many do we have in room? Oh. So it's going to be 3, 4. Uko, can you join room 2, please? Room 2. Bello Joseph, room 2. Abubakar Yahya, room 2. Ahmed Mohammed, room 2. Now we have Jimonu O Favor, room 1. Zainab Kwaru Mohammed, room 1. And Habib Lawal, room 1. On that note, can we all please move out for the breakout session? It's for, we'll soon be coming back so that we quickly round up with another panel symposium, and then we will go for lunch and go back home. Now, we just want to announce, while I was in the convenience, we found this, someone left the glasses in the convenience. Somebody has been looking for it. Oh, okay. So let her, can you forget your eyes? Maybe she has to. Okay. Can we go to our breakout sessions, please? It's just for 40 minutes. Let me see. Sorry. Can we leave? Yes. Breakout 20 minutes. Breakout 20 minutes. Schedule.
Was it 40 we gave her?
No, this lunch. Hello, 20 minutes. We have to work. 20 minutes. Room 1 is here.
Room
And
one
then
is
room
here.
2 is in the fourth room. Yeah, this is room 1.
It's too broadly connected.
They were here.
I would like to introduce the first panelist in no particular order. Dr. Belal Abdullahi. Can we see his handsome face on our screen, please, so that we get to know him? Dr. Abdullahi Belal. Belal, okay, is a public health specialist, pioneer, executive chairman of the State Primary Health Care Development Board of Adamawa State. He is the CEO of Beldon Consult Limited, the MD of Beldon Hospital, and currently, or in the past year, was a co-team lead consultant that facilitated development of a 10-year project plan, I think on the NSHIP project. I wanted it up there. Can I have it up? Okay, all right. He supported Borno State as a construct management and verification agent, and he was also involved in the design of the PBF in Nigeria and contributed to the development of the toolkit. It is therefore the reason why we thought it fit that no other person would do justice to the issue and the topic that he will be taking. Data verification systems for result-based systems, the Adamawa verification experience. Dr. Belal, you're most welcome to this panel discussion. On the same note, I would like to welcome another distinguished gentleman who will be the next slide. I've already read this. You want me to read it again? Okay, do I read it again? No. Okay, so let's take the next person, Dr. Olufemi Adegoke. Is a country manager of the Oxford Policy Management, OPM, has an MSc in Population and International Health from the Harvard University and a BSc in Human Nutrition. He has worked in several impact evaluation and independent verification of several projects before he joined the Oxford Policy Management. Where is it? Okay, with the Development Impact Evaluation Unit of the World Bank on the evaluation of bank and the Nigerian supported project. He has held various roles in independent monitoring and evaluation. He is therefore joining to share lessons learned from implementing independent verification / third-party monitoring by Oxford Policy. I hope, Dr. Olufemi, you're still with us. We want to apologize for the late part of having this one coming up late, but I'm sure you're with us. If you're with us online, please, can we pick him out and also show him on the screen so we know that we are with Olufemi Adegoke, Country Manager, Oxford Policy Management, OPM. Earlier, I talked about having Dr. Belal here. While we pick him out, Dr. Belal, let's look at your topic and your presentation. You're going to be looking at data and verification systems for result-based systems, the Adamawa verification experience. Sir, you're welcome.
Thank you very much. I'm happy to be here. I'm happy to be here to share the experience of Adamawa State, one of the pioneer states that started performance-based financing in Nigeria under the NSHIP project. Yes, please, I think there is a small animation about my name. Can you just click to get that out? Next slide. Next slide, next slide. Okay. I'll just quickly go through the slides, and then that can form the basis for our discussions. We can't have a result-based financing project without data and without verifying those data. And that is why it's very important for us to go through. The earlier presenters have talked about data, therefore we are not going to go into the details of that.
but we'll just look at elements that are very important in RBF programs, and verification is very crucial, particularly to improve transparency, fairness, and viability of the programs. Data that are being presented must be verified. And within the context of NSHIP, MPSCDA was responsible for the provision of the technical assistance. And MPSCDA, the National Primary Healthcare Development Agency, contracted OPM as the RBFTA during the project period. So facilities that are the providers, they normally make their claims through their invoices, and two sets of data form the basis for those invoices. They have the quality and the quantity data that they present. Next slide. So most important from the quality side is that the measurement of the quality is done through composite score quality checklist that is being administered by the local government supervision team and verified by the RBFTA. So the RBFL facilities then submit these claims for the healthcare services that they have provided, covering the population that each facility has been allocated. And all those claims are within the contractual terms of the program. So once the data has been submitted, the RBFTA now is responsible for undertaking the two separate rounds of verifications. And we have the ex ante, which is the verification that is done before the payment, and we have the ex post. These are verifications that are done after payments have been made to those facilities. Next slide. This is a quotation just to show that NSHIP also was a project to fill certain gaps, and it was really important for improving child survival and high impact interventions in health to improve some of the indicators that were already been confronting Nigeria for a very long time. Next. This is just a description of the NSHIP as a project. When it started, it was in 3 states of Adamawa, Ondo, and Nasarawa, and it started since 2011. And there were 2 components, 2 areas. The first area is to strengthen service delivery, and then the second is the institutional strengthening of the performance at the state, federal, and local governments. A combination of the result-based financing were adopted in the NSHIP 1 project. We have the RBF where the DLIs are done to improve the governance at the state and local governments, while the PBF and DFF later was introduced at the service provision level. So as I have said earlier on, OPM was contracted by MPSCDA to provide the technical assistance, and mainly verifications are done by the technical assistance. Next slide. The screen, maybe the bigger screen will show you that some of the principles behind these verifications. At one end, priorities have to be set. Those that have been identified, just like we are talking about the services or the service packages. And each of those services have to be costed to be able to provide the fees that have to be used to purchase those services. And then the service goals are prioritized and then are weighted. The functions in terms of the institutional arrangements also have to be agreed upon, and there will be clear separation of functions between the players. And business plans have to be developed in order to guide how much level of work has to be done. So as the services are being provided, we are expected that to have the improvement in terms of the service provision, which later on we'll look at the quantity and the quality of the services that we are talking about for ANRiN. There is going to be also increased accountability, the autonomy of these facilities, because it's one of the elements for performance-based financing. The providers must have some degree of autonomy. And the autonomy is talking about the ability to hire and fire staff, the ability also to use cash, because prior to ANRiN, these facilities were not getting allocations of resources, particularly cash. And they should also be independent in terms of their planning and implementation of their own plans, according to the approved business plans that they have made. Then the financial autonomy, as I have said, will improve the way the facilities will function. So after the service provision, these verifications happens, and then payments are based on the verified services that have been provided or produced. Next slide. As I have said, there are two types of verification: the ex ante, which are done before the payment is being done. So basically, the invoices that have been provided or produced will be looked into. They go into the registers, other documents to validate those invoices, and then payments will be made. Next slide. And the ex post verification is done after those payments, usually at least twice in a year, where another verification, samples of those facilities, not all of them, but later on we found out that many of those facilities, they hide under other facilities when sampling is being made. But normally, randomly, some of those facilities will be checked, and then if there are discrepancies, then sanctions will be applied across board. Next slide. So the following slides are just showing the packages, the indicators that have been selected for the services in ANRiN. We have the MPA, which is the minimum package of activities, and the CPA are the referral services in the secondary health facilities. Next slide. All these ones are the same thing, just showing the list of those services. Next. There are services that are exclusive for either the MPA or the CPA facilities. But we have many of them are similar because the level of service implementation, for example, antenatal care, can be provided in both primary facility or secondary facility. That's why we have common areas for those services. Next. So these are some of the data that they started coming out. This is percentage coverage of OPD attendance. The first areas, the first few months or few years were the data from the pre-pilot local government, which did not include the DFF because it's only one local government. And half of the states were now implementing PBF while the other half implements DFF. So by the time OPM came, already implementation of both PBF and DFF has started, and therefore the data they have collated have shown that there are progress in both the PBF and DFF facilities. Next slide. These are also the indicators showing the quality aspects that are being monitored or being reported. Next. And these are exclusive indicators for the quality for both MPA and PBA and CPA. Next. Next. Verification is very expensive. You can imagine, like in the UK, the NHS spends more than £1 billion annually on verification. So it's not a cheap thing to be able to get data that is reliable. And if nutrition program wants to do a result-based approach, they should also be prepared to set aside large quantity, enough money to ensure the data is clean and then it's validated and it's reliable. So it doesn't come cheap. This amount they spend only on they spend only on 4 areas, but those areas have many other sub-indicators. But their data, they collect them using technology and on continuous basis instead of intermittently. Next. So the result of verification provides information on the sanctions. And as it's being calculated, depending on how much they vary from the normal, the sanctions will be agreed. If the discordance is above 10%, for example, you can have like 20% reduction in your income. So something like that can be agreed upon to deter those providers from falsifying data. Next. These are just examples for the MPS and the CPS. The general hospitals too are not left out in the sanctions. Next. This is the institutional arrangement for NSHIP. And these structures, as all of you are aware, that they are still existing and can be leveraged upon to be used by the nutrition program when we're talking about integration. Next. There are also many committees, so we don't need to reinvent the wheel. We can use the same committees, the same work plans that they have to enrich and integrate into. Next. These are the areas where the RBFTA worked in getting their information and relating with the players in the public sector. Next. So in terms of successes, verification and counter verification have improved documentations at all levels, as has been testified by prior presenters. It has also curtailed number of phantom patients on registers. It has improved actual quality and of the health units providing services. It has made offenders to accept their mistakes and make corrections, and also identified capacity issues and recommended remedies during the project implementation. So there was nothing that was stagnant. Everything was, we were aiming at improving the quality and the quantity of services at all times, and ensuring that the quality of service is topmost. Then the costs from the sanctions were also plowed back. There is no wastage. We get more money from the sanctions, and then we improve quality as we move forward. The challenges were the pure human capital. The nutrition program has more people than when we started in NSHIP. The bureaucratic bottlenecks are still there within civil service that people have to also cope with. The funding of routine budgets, because there are a lot of other assumptions in setting these fees. For example, when commodities have been agreed to come from partners, and then suddenly those commodities are not coming, therefore, some of these inputs have to be found, people have to find a way of getting them by the budget lines of the government. So delays in payments of subsidies have also been noticed because of some of the bureaucracies and the way the project was structured. So frequent worker strike has also been talked about, insecurity in the area, and gaming. So when there are result-based approaches, gaming is one of the areas that the project has to put eyes on. So lessons learned, a hiring of Oxford policy manager as sole verifiers created conflict of interest, because it's expected that as TA, they should also build capacities. But when they are doing verification, they're also noticing that the low capacity is leading to some of the issues. And therefore, there were some of this conflict of interest there. And therefore, the correction was made when NSHIP is being scaled up to other 5 states. And the TA became CMVA, Contract Management and Verification Agents, and independent verifiers, working independently. The DHIS data also became very close to the PBF portal data because of those data checks, as has already been say. Thank you very much.
Thank you very much. I'm constrained to say we have to stop, but thank you very much. We have all listened. Thank you, my brother, my colleague, my senior, everything. There's so much we look up to you about and all the work that you've done. Thank you for this presentation. And you did talk about Oxford as you were rounding up. Maybe it's a good opportunity for us to welcome Dr. Olufemi Adegoke. We understand he's online. We would like to take his own 20 minutes if he's here. Can we showcase him online so that we can also take his presentation before we now take questions? Sorry? I gave you, that was only on 5 minutes. Okay, there he is. We welcome you to this platform and want to apologize and thank you for being so patient and staying on. So we'll just take yours now. We'll give you 15 minutes, a little injury time might take you up to 20 minutes, or if you work within that 15, we'll be very happy. Let's hear you. After that, we'll take questions. The good thing about this, there's no breakout session, so all the questions will be asked right after yours. Please go ahead, Olufemi, we welcome you. Let's please applaud him and make him feel warm as he enters into the arena. Thank you.
Thank you very much. Thank you very much. And I'd like to thank Dr. Bella, who's made my work extremely easy. Having cited some of the things we've done with doing the ANRiN program in Adamawa State. So according to the program, I was only given 5 to 10 minutes. So I made my presentation so concise because I know my presentation is standing between lunch, and I'm sure that everyone is eager to get that. So I just have like, the overview is I'll just give you some backgrounds and some key lessons learned. So Oxford Policy Management, we've done a couple of independent verification work for several service delivery projects. So I just wanted to just put together in a very concise manner some of the key lessons learned from doing this type of work. So first and foremost, many implementers see the role of an IVA as a policeman that scrutinizes their results. And I just wanted to just sort of change that conception. What independent verification agents do is they help programmers, support them in monitoring and verifying their results, and equally help them in achieving and adapting their ways to achieve greater impact. So it's always important that we change that notion that an IVA agent is as a police officer who's just coming to, when people see here IVAs are coming to town, they're running helter-skelter, and that's not the case. They should see them as a constructive partner that helps them, supports them in the work they do, ensuring that they have better and more results. So we've done a couple of these on several projects. Dr. Bellal has shared extensively the work we did on the ANRiN project, which was in Ondo, Nasarawa, as well as Adamawa State. And he's spoken extensively about that. We've equally done, the independent verification agent for an FCDO project called the Women for Integrated Sexual Health, which is a multi-country project. We've also done a couple of other third-party agent monitoring for various, so we have extensive experience. So one thing I wanted to share, and something that Dr. Belen had already touched upon, is that whenever you have a performance-based contract, you will see a similar trend that what I'm showing you on the screen. So you have, normally before the PBF kicks in, you have like a low, and then suddenly you just see an upward trend, and sometimes it's of implausible values. So, and this is due to the fact that there's a tendency or high propensity for people to wanting to game the system for their own personal interest rather than public good. And, it is important that people oftentimes want to earn more than what they deserve. And so what an independent verification agent does in this case, it helps to verify and validate the results of their achievements, so that, in other words, people are paid what they well deserve. And so I just wanted to just quickly, in a very, very short and concise way, just tell you what are the key lessons learned from a couple of different IVAs that we've worked upon. And when I say lessons learned, I wanted to just put in perspective, I just wanted to keep 3 lessons learned, just 3 of them. Now, the first thing is that for a successful IVA, you need to work very closely with the implementing agency. Now, it is important that both implementing partner and IVA are clear and understand the performance indices that are being measured. They're clear about how these measurements are going to be and how it's going to be reported, how it's going to be collected and reported. Now, if you miss out this fundamental step, right, it is a complete recipe for disaster. So oftentimes, some of the things that Dr. Bella shared, where discrepancies come about when both provider and verifier lack this clear understanding of what and how to measure these certain indices. The second lesson that I'd like to share, sorry. Having a defined set of verification activities. Now, of course, it's important that both implementers as well as a verification agent know exactly the set of verification activities that are going to go and how those things are going to be performed. Now, in most cases, there might be different levels. Dr. Bella shared the ex ante and ex post verification that was done in the RBFTA. That's one approach. But there might be different sets of verification activities that we prescribe, and they can be at different levels. Some might be DEX-based, some might be site-based, some might be beneficiary-based. But it's having a clear understanding of these sets of and the chronology of how these activities is usually helpful in ensuring that both implementers and IVAs are on the same page at all times. For instance, one set of, if on an ANRiN project, there could be verifications at 3 levels. One can be DEX-based. When we say DEX-based, this is just looking at the global picture of all the achievements reported at each site level, states, local governments, and just mapping it out across the flow. And of course, in some cases, you might now decide that might lead to further site verification, which can either be randomly sampled or in some cases purposively sampled. In some cases, purposive samples are done based on maybe significant outlier, or when results look suspicious, people tend to want to say, okay, let's go and verify this one and check it out, as opposed to just normal random sampling, which could pick any of the two. But when this is done, it is really looking at what was reported versus what you have in the primary source document versus what was reported. So that's another level of verification that can come to play. Now there's a third level of verification. Okay, yes, we have a register, we reported 100 people, we in the source document we have 100 people. We could also consider further validation of those numbers by actually saying, okay, this 100 people, let's see if we can reach 5 or 10 of those people. So what do? We then either call or try to reach out to and try to see and ask a defined set of questions, which could be either to ensure that, is this the person who allegedly received the service? If that's the person, what service did the person, when did the person receive the service? What service did the person receive? And just understanding the set of questions. And those set of questions help to establish whether or not indeed we can validate such findings. Now, the third and most important lesson that I think is useful here is, if and when we find discrepancies, how do we address them? Of course, Dr. Bella mentioned some established discrepancies that were, there needs to be a defined minimum error, there needs to be a defined margin of error, right? And if things fall outside of that margin of error, how do we deal with it? In fact, on the first instance, how do we share, how do we ensure that how do we feedback these discrepancies to the implementing partner so they can make corrective action in ensuring that they strengthen their own data systems and their own data flows so that those things don't happen. And then in some cases, we need to think of, what are the likely sanctions, like Dr. Bellel had shared. So
We don't
again,
have more time, 5 more minutes
again,
as injury time.
I mean, this is like I said, I was just going to present 3 key lessons for you: having clarity of the methodology of the indicators, verifying them, and putting in place a mechanism in addressing those discrepancies. So thank you very much, and thank you for your time listening.
Thank you very much. Right on the money. Data bricks. What will we do? How can we make bricks without clay? Verifying and validation. I want to appreciate you, Dr. Bellel, and also Dr. Olufemi. This is very, very good, and I'm sure there'll be a lot of questions. Like I said, there's no breakout session, so please, I know 60 or 61 people are online. Those of us here, please, let's have all the questions. I know the hypoglycemia and other glycemias and amias have set in, but I think also we can ask some of these valid questions because Anthony told us about the importance of data to our planning, even to the government, even for advocacy. We need data. It's only when we have data that we can plan appropriately and provide appropriately for the resources that we require for these women and children. And like when you set up ANRiN, you had targets, and that was based on data. What you have showed us today also, and what we have done is through your data. And I had a lot of questions on how do you verify, how do you validate? So let's have the questions, please. By raising your hands, even if you're sleeping. I know somebody in my school that used to sleep with one eye doing exams. So I believe that 60 people online, those of us here want to ask questions about the methodology, what they have said, experiences, especially around the challenges. For you in ANRiN, they've highlighted these challenges. Do you see it? My question is about gaming. What is gaming? Because those of us, there was in your presentation, Dr. Bellel, one of the things you mentioned was gaming. I want to know what that means. I don't know whether we have questions online. Any hands up? Can somebody? Any questions there online? Cletus, do we have any questions from the LOC? Do we have anybody online, please? They've looked at the methodology. We have somebody from Oxford Policy Management, and they worked with us in terms of validating what happened in ANRiN. Earlier, I think yesterday, we talked about ANRiN, talked about ANRiN, questions about you've given the mother iron, okay, access, so how do you validate? And they've had to, I think you answered that question about how you verified and how you validated, and today you have told us. Do we have any questions? No question, this is serious. So let me ask the ANRiN says, have you started verifications? You have not started verification. So is there anything you want to learn that will help you prepare for when they come for verification and validation? You have given us results. People asked you. So they've talked about the methodology. What is it that you want to know? What do you need to put right? What do you need to look out for, especially with the challenges? Do you have any of those challenges? Nobody wants to ask that question. Right, sir. So answer mine then on gaming. Okay, Cletus, can I have the questions you have there, please? In school, we have people, when it's maths class, everybody jumps out of the window. They say they are doing Igbo BK. This maths, you know, grade them. Now we had data, we are thinking it's maths. So we hope our online people are on, and I'm sure you have questions to Dr. Bellel.
Okay.
Yes.
Thank you very much, presenters. One of the presenters talked about the ex-ante and the post-ante verification. So which one would you recommend for the ANRiN project and why? Thank you.
Very much. Do we have any other question? None. So Dr. Bellel, they are asking, what would you recommend for ANRiN?
Well, thank you very much. OPM is there, but in verifications, both are important. In order not to delay, you need to do the ex ante to be able to pay your providers. But definitely over time, you need to also check that what you are paying is validated. So in between, you can have, I can still answer her own question. the gaming can happen. What we mean by gaming is that connivance between the verifiers and the providers at any point in time can also falsify data, and then people can share the proceeds. So once that is happening, in an RBF project, it's called gaming. So we don't call it corruption, although it is a form of corruption. You understand? So you need to be on top of that game as managers. I hope I have answered the two questions. So you can't choose either. You need both. Yes, you need both in your design. If you are doing, particularly if you have to do PBF program, performance-based approach, you need both. And in performance-based, there are three aspects that is being checked. You check the quantity, you also check the quality, but you also need the client satisfaction. So there are surveys that can be done at regular intervals to be sure that your clients are also part of the clients are being carried along and they are satisfied. In universal health coverage, those three outcomes are very important. You know, looking at your health outcomes, then the quality and access, and then the issue of the satisfaction. Satisfaction and risk protection. Those are the three components that form universal coverage. I hope I have answered the questions. Thank you very much.
Thank you very much. Okay, you have a question there. Do you have a question? Okay, please, can we give him the microphone? Then after that, we give the beautiful lady to the right. And the handsome young man there wants to ask a question. Please go ahead.
Good afternoon. Thank you very much, Dr. Bilal, for the presentation. And I think when IVAs go for verification, I think there's a window period where they sit, like in ANRiN, I'm sure the design for ANRiN and ANRiN have some differences, because just like you said, for ANRiN, verifiers go to facility to take the quantity. But for ANRiN, there are no verifiers that will visit facility. So, and I know that sometimes when IVAs go for verification, the state SPACDA do some client tracing. So will ANRiN project, will it suggest that when IVAs do their verification, they should give some window period where we can do client tracing? Because sometimes the challenges are from the CBOs who go to do those verifications. So will you suggest that ANRiN projects should have a similar procedure? Thank you.
So I want to appreciate you for that wonderful presentation. I still want you to throw more light on that independent verification agencies. Not clear.
Almost the same. How do you deal with verification processes that are compromised by the IVAs? For instance, failing to report discrepancies because of possible sanctions. I think we'll give this to Olufemi. Olufemi, how do you deal with verification processes that are compromised by the IVAs, for instance, failing to report discrepancies because of possible sanctions? And the other question was around, what is your recommendation to ANRiN? Should they also deploy the same, both having that window period you asked? That was your question? All right, so those are the two questions. And you wanted more on how this
Thank you very
much. Here.
Can I go ahead? Okay, thank you. So just to quickly answer the question, Please note that even IVAs are indeed human, and sometimes they might get their own. So that's the reason why I said there needs to be some mechanism between the IVA and the implementer in trying to resolve certain levels of discrepancies. So just like implementers, the IVAs are and oftentimes are also bound to errors. But the question that you asked was around the this is absolutely not acceptable when an IVA fails to live up to its own responsibility of dispensing the duty it was contracted to do in the first instance. What is their duty? Their duty is to be independent. Now, because to be able to, it's almost impossible for an IVA to work in isolation without working in close constant with the implementing agency. But they should never indeed lose their independence. And their independence is to report first and foremost to share discrepancies with the implementer. There should be some mechanism in which such can be resolved. In certain cases, such discrepancies might be as a result of sampling errors or some things that can be explained or clarified by the implementer. But in the case where the IVA knowingly fails to report certain discrepancies over and above certain thresholds, is totally unacceptable and unethical. And so that is not acceptable. The second question was around whether or not, I mean, I think the ANRiN project is slightly different from the NSHIP. I don't think that everything that you can copy and paste shamelessly, everything that was done on the NSHIP. I think the NSHIP, there's a lot of learnings from the NSHIP that we will take away in improving how you verify programs as robust and as dynamic as the ANRiN program. I think that this, would so I won't necessarily think that you should copy and paste what was done on the NSHIP. I think the NSHIP, there are loads of lessons learned from the NSHIP, and I think that a lot of these lessons can be brought forward and applied. I don't know if I've answered those two questions. Over to you, Madam Moderator. Okay, sorry, there's a question online whether an IVA can truly be independent if it's hired by the same entity that is implementing. Oftentimes, IVAs are not necessarily hired by the implementing agencies. They're usually hired by a donor and oftentimes, but again, like I said, many a times IVAs need to work in constance with the implementing agencies because they can't work in isolation. But in doing that, they need to strike a right balance so that they don't ever lose their independence in dispensing their duties. Over to you, Madam Moderator.
I'll invite Belal. Do you have any other something to add on to this? And then
Well, I think he has answered because the implementing agency does not hire IVA. It's, usually it's the donor or the owner of the project that hires the IVA. And the IVA becomes independent in advising the funder of the project the issues of the discrepancies. The question that you ask on the issue of the window of opportunity, I mean the window periods for IVAs, I think you are mixing the role of the IVAs and CMVAs, which made the work of OPM also difficult when they were hired to provide TA as blanket TA during the first part of NSHIP. So CMVAs do the checks of the data, and as soon as those are okay, then they are also part of the agreement with the providers that this data is okay, and then they can get their ex ante approved and get the payments. So while the IVA does the ex post, and if those discrepancies now exist, after that, the sanction can be severe. And that can also affect the integrity of the CMVA.
Thank
Is that
you.
okay?
Thank you very, 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 very much, Dr. Belel and Dr. Olufemi. You really made our day because a lot of questions were around data. Even there's this lingering one for Dr. Anthony, who will try to convey it. He said, how will the DHIS support ANRiN implementation such that historic data will always be available and accessible, because currently 2019 data is not accessible on a DHIS2? That was, they've answered it, okay. At what point and how do we validate all coverage data? I think they've also collected through DHIS. These are lingering questions that have been sent online. So thank you very much. Please, let's us applaud both of them. Let's thank them for their presentation. It's been wonderful. And I think the ANRiN people are now relaxed when they are talking about verification and validation. They understand what will happen, and it will be hands-on, and the process, there'll be no gaming and none of those things from my ANRiN people. So thank you so much. And to say also, it's been a pleasure to moderate this session. I'm happy. I'm one of the last. It's good to save the last, but we're not saving the best for the last. But it's been a pleasure being here also and participating. I'll now give it back to the MC. Thank you, Dr. Belel, as we escort you back to your seat. Thank you.
Thank you, Dr. The moderator for the last panel symposium. We want to appreciate you, indeed appreciate you. It's been wonderful, fully packed. And we also want to appreciate the panelists. Thank you, Dr. Nde. Thank you, Dr. Abdullahi Bella. We're most grateful to have you here with us. And Mr. Olufemi Adegoke, we indeed thank you. Thanks for your presence, thanks for your participation and all the knowledge that you've been able to transfer to us this day. And on that note, I want to call on, we're almost done. You know, it's like when you start a race at the beginning, oh my, there's so much energy put in the race. But at the time you're almost at the end of the race, it's like, oh my, when am I going to get there? But truly and truly, we are almost there. So bear with us for the next, not even up to an hour, you know, some few minutes more, and we'll be done. We appreciate you indeed. Now we have Mrs. Rekia, who will be coming up to give us the communique for this conference. Mrs. Rekia Idris, you will all agree with me that this conference has been most exhaustive, highly comprehensive, with very, very high expectations. The enthusiasm visibly shown on everyone here, not just here, participants even online. It has been really amazing for us. And so a lot of knowledge has been transferred. A lot of new things have come on board. We've been able to learn, especially some new best practices have been showcased, both national and internationally. We have also been able to, it's also interesting to know that the full demonstration has actually increased the uptake of ANC in most of the states. This is very, very interesting for us, and it's quite encouraging. And it tells us a great story that yes, indeed, people are out there doing the work, working a lot to ensure that our children have a better tomorrow. Our children have a better standard for them to be able, because when they have adequate nutrition, we all know they are better fortified and they have a glorious life ahead of them. So we are very happy that this conference is almost coming to an end. And we're excited with all the knowledge gained. We're excited with all the best practices, the shared experiences that we have had here amongst ourselves. It is my desire, or I hope, that when we leave this place, definitely we will begin to
have models, come in our various states. Because knowledge gained is never lost. Whatever we must have gained here, we need to go back and step them down, in various states when we get back. Mrs. Rekia Idris, are you ready? So that I don't talk too much.
Hello, everyone. Both virtual participants and online participants. And thank you for still being around for this. So we're about to have reached the final of the 2-day, very hectic conference. You will all agree with me that we had very fruitful and enriching discussions, both at the plenary sessions and also during the panel discussions and breakout sessions. So what we are going to do now, we're going to look at the communique. By the way, my name is Rekia Idris. I'm head of IYCF, Federal Ministry of Health, Nutrition Division. What we're going to do this afternoon is to look at this communique and see what we have put up. And then everyone here, this is not cast in stone. Everyone here is expected to tear it apart and let's have a better a better communique that will result from this conference. This is just a draft that has been presented. And at the end of the day, we will all do the recommendations because we, the LOC members, cannot recommend for the conference. So we'll just put up some resolutions and what we all agreed on. And then all the conference participants, both online and physical, are expected to give us some of the recommendations that will be included in this communique. Do we all agree with that? Okay, I hope, can you put up the communique so that who will read it? Please, I beg your indulgence. There is need for us to read it line by line so that we know exactly what has been discussed, what we have learned, and what we need to agree on. So that at the end of the day, when you leave here, you will know that this is all what each and every one of us has agreed to do or has agreed that the government needs to do. So with that, I would like to find out if it has been presented. Projected, thank you very much. I think most of us can see what is being projected. So I will start with the heading. First, communique issued at the end of the 2-day joint annual result conference organized by the Nutrition Division, Federal Ministry of Health, and Nutrition Division, National Primary Healthcare Development Agency, with technical support from the World Bank, held at Hawthorne Suites, Abuja, from the 27th to 28th of April 2021, with the theme, leveraging performance-based financing to improve nutrition service delivery in Nigeria. Now we have the overview. The nutrition divisions of the Federal Ministry of Health and National Primary Healthcare Development Agency, with technical support from the World Bank, organized a 2-day joint annual result conference from the 27th to 28th April 2021. The two-day conference had presentations from diverse institutions, stroke organizations, and subject matter experts. It was a robust engagement of ANRiN program officers, the academia, and subject matter experts during plenary sessions, panel discussions, and breakout sessions. The objective of the conference were to share experiences, lessons learned, innovative approaches, and evidence-based results from ANRiN project in Nigeria, and to share national and international best practices for performance-based programming for improved nutrition service delivery. That is one paragraph. Do we all agree with that? Chiamaka, are you with me? Mrs. Orume, sorry, Pharmacist Orume, are you with me? Please, okay, for the comments. Thank you very much. Do we all agree with the first paragraph? Okay. No, that's it. They said they agree with that. Okay, okay.
Nutrition division should come after.
Then nutrition division. Okay. I'm making the correction on the computer. You might not be able to see the corrections there. So, okay. Any other comment? The participant online, can you put your comments on the chat box if you have any as we move along, please? Thank you. Then the second paragraph. The conference started at 9:30 a.m. with the commencement of the technical sessions. The opening ceremony was postponed to afternoon to accommodate the Honorable Minister of Health's schedule. The two-day conference had in attendance 425 participants, with 92 physical attendees and 333 virtual participants, drawn from key stakeholders from diverse institutions or organizations in Nigeria and outside the country. The 12 ANRiN implementing state, federal and state program officers from ministry, departments, and agencies, Federal Ministry of Health, National Primary Healthcare Development Agency, World Bank, development partners, and the media, amongst others. Do I continue? Yes. Who will put Cletus? Please help me give him mic, or who is there to give mic? I think so, yes. Can you put up your mic, please? Your hand.
Yeah, sorry, when you mention MDS, don't you think it has covered Federal Ministry of Health and National Primary Care Development Agency? Because you mentioned MDS, then you move down on.
Okay.
Except if there is how you can qualify that.
And maybe MDS then in brackets.
To make it like more emphasis more on Federal Ministry of Health and National Primary Care Development Agency. Else, you mentioned MDS already, and they are part of that MDS.
Okay.
So that it shouldn't look like a tautology. Thank you.
Okay, thank you. Fine. Okay. Okay, someone's hand is also up. Okay, so that should not come in.
It should not come in. Just say it was the Honorable Minister opened. Yeah, thank you.
Okay, the Honorable Minister opened the conference. Okay. Okay. Fine. Then let's continue. Then The next paragraph, we have the conference keynote speaker, Professor Bina Onwujekwe, presented his topic online, leveraging results-based approaches to improve nutrition service delivery. The professor applied his diverse experience to illustrate the different performance-based financing and its application to nutrition interventions. He stated that performance-based financing is output-based rather than input-based, and concluded that performance-based financing can improve supply and demand. Can I go on? Yes. Can improve supply and demand for nutrition services in Nigeria if properly designed and implemented as a provider payment mechanism. Also, issues on design and content should be taken into consideration as no one size suits all. Adequate funds have to be mobilized and efficiently put before the funds can be used strategically to purchase and robust public or private financial management systems should be part of any performance-based financing scheme in Nigeria. It's disjointed. So can you say the full story then? Can you help out with the English then? Can you give her the mic, please, so that she help us reframe that paragraph? Who has it here?
Just for adequate, where are we again? An efficient pool, where are we? Where is that? Adequate funds have to be mobilized and efficiently pooled before the funds can be used strategically to purchase, full stop.
Okay.
Or rather, comma, just put in bracket, public or private.
Full stop.
No, to purchase, comma, put in, remove and robust.
Okay.
Public, private, public or private. That should be in open. Yes. Public, no. They should, purchase, comma, and robust, remove. Then you put in bracket, public or private. Are we together?
Yes.
Yeah. You have another view. Financial management system should be part of any.
So I've been asked. Hello? Okay, are you done with that? So the next paragraph, we have the opening ceremony, which talked about the permanent secretary. I'm asked to just give a summary so that we just go to the recommendation so that we don't waste time. This can be rewarded later on. The opening ceremony held and welcome address was delivered by the permanent secretary, Ministry of Health. The Honorable Commissioner of Nasarawa State gave the goodwill message and he supports the ANRiN project. The Honorable Minister gave the keynote address and he highlighted the need to tackle malnutrition scourge as a priority. And this was followed by a vote of thanks by the Director of Family Health Department, who appreciated the participants that took our time to be present, both physically and virtually, despite the pandemic. So now we have over the 2-day sessions and presentation of 24 papers and very enlightening and rich discussions. The participants at the conference, one, noted that professional responsibility and commitment to improving nutritional status of women and children to reducing maternal newborn and child morbidity and mortality, full stop. Noted that effort to generate, share, and use evidence to improve effectiveness of ANRiN and other nutrition programs is fraught with a number of challenges, among which is data management, and so on and so forth. And then the participant also agreed that it's important to develop and implement accountability and anti-corruption mechanism within performance-based financing provider payment mechanism for optimal, efficient, and equitable use of available resources. They also agree that quality improvement and timely dissemination of quality data are essential if health authorities wish to maintain health and nutrition care at an optimal level, and emphasize that simple community health and nutrition information system tools and standard of practice needs to be developed. Then the last and not the least is acknowledge that the Joint Annual Results Conference creates a platform for knowledge and experience sharing, especially on best practices, nutrition service delivery, and information dissemination. And then recognizing that National Nutrition Program requires strong evidence base to improve delivery of high impact, cost-effective, and scalable interventions in Nigeria. I'm just giving you some of the write-up, not all, because I want to fast-track the process. And then recognize that the use of electronic information repository for nutrition can strengthen data-driven policy and nutrition program designed at all levels. And then now we are now to resolution and recommendations. In view of the above and in recognition of the effort to improve the implementation of ANRiN project for increased demand of services by beneficiaries, the participants hereby agree on the following recommendation and commitment. So now it's where all of us needs to come in, and let's have your recommendations and resolutions for the conference. Who will start by giving us one recommendation? Is there anybody online? Do we have anyone online that will give us one of the recommendations? Can we have a recommendation, or do I call names? So what I will do is that I will call each of the states that is present here to give me one recommendation. Yes, please. Who has the mic, the second mic, please? Chamaka, be ready. Pharmacy Bright, Beatrice, be ready. The recommendations.
My name is Amina Adam from Katsina State. I am very glad to have this opportunity to be with you here to attend this 2 days conference meeting in Abuja. My recommendation is about all the organizing committees that have the time to sit down and plan and organize all the 2 days program successfully and history. Thank you very much.
Okay, thank you. So we have one from Kaduna State, and then let's have is there anybody from Oyo State? Oyo State, please. We need one recommendation from your state. Who are the members of Oyo State here? Oyo State. Is there nobody in Oyo State here? Yeah? They've stepped out. Okay. So can I have a recommend from Kwara State? Kwara State. Is there anybody online that has a recommendation for us? No recommendation from Kwara State. So let's have recommendation from Kogi State. Anybody from Kogi State with recommendation?
There's a recommendation here.
Okay, hold on.
Good afternoon, everybody.
Good afternoon.
We really appreciate this conference for bringing us together to share our experiences at the field. I want to indulge the organizers that this is the first time and we have really learned a lot. And we are going to improve on this by the time we start having subsequent conference like this so that we can improve on our services.
Okay, we have one online. Okay, there is one there. Fine.
Yeah, I still want to congratulate the organizers. And I think my recommendation here is we should keep it up to do both online and virtual and physical conference, because that has given opportunity for the organizers to actually have a lot of participants. Now imagine looking for a hall that will accommodate up to 400 plus people. It's not going to be an easy task. I'm recommending that when next we're having this kind of conference, we have both physical and online conference.
Okay, thank you for that. Then, yes, there's another recommendation from Abia.
Thank you. I'm Jimon Ofavor from Abia State. Please, I want to recommend that when next this kind of meeting will be called, please let the national remember to include our SPSCDA M&Es, since they are also in the list for supervisory visits at the PACs, and they also assist us in doing the MIE work at the SPSCDA. I don't know if we can hear me. I'm saying that the only recommendation I have is that when next this annual conference will be held, the national should remember to include our SPSCDA M&Es. Thank you.
Okay, thank you for that. Then, yes, there's another recommendation.
Thank you very much.
Thank you.
Yeah, my recommendation will be drawn from some of the discussions we've had today, especially that the one concerning data, right? Most SPACDs lost data that should have a kind of fast-tracked achievement of their results in the first year of implementation, because they have not been migrated to the new DHIS2 platform. So I would like this conference to recommend that the Ministry of Health should fast track the enrollment, or the what do we call it now, migration, of all the ANRiN states to the new portal to help address the issue of data loss due to the use of the old version of the DHIS2 portal. It should be mine. Thank you.
Oh, thank you for that wonderful contribution. Let me hold on, please. Just a minute. Hold on. There's someone who wants to speak online. So let's have that, then we can now go with you. Can we have that, please? What's the name of the person? What's the name, please? Is the online participant ready? Just wait, don't worry. Is the online participant ready? Okay, let the participant come on.
Hello, is it Lois Onyike you have given permission to speak? Hello?
Yes, speak.
Thank you very much. I wish to congratulate MPSCD and Federal Ministry of Health for this wonderful conference. It's not just for ANRiN State. That is just the point I want to make. Let there be improvement on data reporting from all this, on nutrition from all the states. Because when you look at data from all over the world, we will have minimal data from Nigeria on nutrition. And also, if it is possible, we need to review what is being reported that the DHIS2 requirement for nutrition. Because when the data person was giving his lecture, I wanted to say something, but I just left it. To report on, is the child growing well? I don't think that is good enough for nutrition. There are basic indicators we should send for anybody to say, say this child is growing well. Child is growing well depends on what the person knows. So it is better if we can look into the indicators that are being reported on nutrition on that DHIS2, so that it could be, if it could be reviewed, it can be keyed into the process or whatever they are doing around that platform right now. That would be wonderful. Thank you very much.
Oh, thank you, Laos, for that. Can we have, there was another hand up. Please, let's give her a round of applause. At least she was able to join us online. Can we have, there was another line up. Oh, we've lost that. Okay, there is one here. I will get to you. She said it's an add-on to the former speaker. So let her just add it on to it. Okay, start on.
Okay, good evening, everyone. I really want to thank the Federal Ministry of Health, MPHCD, and World Bank for this conference. It has been wonderful, and from my own perspective, most of the objectives have been met. But if you're having a project that is result-based, then data quality is key. And in states, we're actually battling with that. So an add-on on the migration is the fact that on DHIS2, there's duplicates of facilities affecting data quality. And then also on DHIS2, the Health Facility Registry, which is a great innovation from the Federal Ministry of Health, has taken a long time to fix the list of facilities on DHIS2. So I'd like if we add that to the recommendations. Then secondly, there are fantastic policies and innovations that have been shared today that haven't reached some of the states. I'm speaking from Plateau State, and we're yet to really roll out DQA and the ISS tools that were mentioned by the presenter here. So that's something that will be highly beneficial. And lastly, it would be nice if we give due consideration to presenters. Amazing presentations, but there wasn't enough time to get a lot of content. I found it a bit of a breeze through. So if we can have more time here to gain knowledge, we'll really benefit and share more when we get back to our states. Thank you.
Okay, thank you, sir. Yes, sir.
Yeah,
At the back there. Thank you.
Thank you. Yeah, what I want to recommend here is that one, individual states should use the result of this conference as an advocacy tool to the state policymaker for increased funding for nutrition. Then one other thing is that the conference should extend to other nutrition stakeholders to join. The subsequent conference should extend invitation to other nutrition stakeholders. Then at the same time, the missing data elements, the backlog of data element in the DHIS, which Cletus have just said, there should be a room that those data elements can be uploaded. For instance, from September last year to December, since the platform just allow after 3 months. So there should be room that this missing data element should be uploaded on the DHIS. Thank you, Joseph.
Okay, thank you for that. And then there's one Bilkisu Abdul, who is an online participant, and she says that capacity building for state and LGAs should be key. That's one of our recommendations. Any other? Yes, please.
Okay, thank you very much. Amazing presentations from all the states. I would suggest that the conference should have a compendium of all the lessons learned and innovation and share with all the participating states so that when we go back, you can learn from the best practices that has been discussed here. And again, secondly, I would suggest that for the next conference, the states should have the same template for presentation. You can see different states having varying presentation design templates. So there should be one template with the same guide. And again, they should have best practices and innovations written clearly in their presentations, which I notice is missing in some of the states. Thank you.
Okay. Thank you for that recommendation. Yes, there's one there.
Good afternoon. My own is more of observation from one of the recommendations that was made over the issue of this M&Es. Please, I don't know, a project. I have not seen a project that is having 2 M&Es at the same time. We are having M&Es at the PIU of each state. And the MIU at the PIU of each state is the lead of the project M&E. To avoid conflicts or to avoid any issue. M&E at the state, I was the HMIS and M&E at the State Primary Healthcare Development Agency in the state before becoming the M&E for ANRiN. So we can work together from the PIU to the State Primary Healthcare Development Agency at the community, LGS and the community. That one, there is no any issue. But to pull the activities, or I can say, have 2 M&Es in one place, or trying the state primary healthcare focal person to initiate or introduce an M&E at the state primary healthcare, then there may be an issue. Please, I'm recommending that these things should be looked into for the next, to avoid any issue.
No, can you come again, because I didn't understand you well, so that we know.
A recommendation was made, ma.
Yes.
That next annual conference, the M&E for the State Primary Healthcare Development Agency should be inclusive in the next annual conference.
Okay.
So I'm thinking of issues that we have been having in the states. This recommendation should please be looked into to avoid more problems, please. Thank you.
So apart from the ANRiN M&E, we should also invite the M&E from the state?
No. What he's saying is we shouldn't combine 2 M&Es at the same time.
Okay.
Yeah, because we only have 1 M&E in the project. Yes, that is the M&E from the PIU, not from the SPSCB.
Let my director come and speak
Oh,
on
no,
that.
it depends.
It looks like they don't want us here as well. We shouldn't be here. So MPHCDA and the Federal Minister of Health shouldn't be here in this conference. But my understanding is that M&Es, even the people you are online, we had to, because of the COVID, make sure that some people are online and some people are physical. So it is based on the proposal. We're all part of that proposal development team and all that thing. 5 years after this one, they will review, and considerations from what you have said will go into it. Now we'll just run with what we have, but all of us have signed, our chief executives of our ministries and from the state have signed on to how many M&As, how many M&Es. Thank you for noting that. It will put aside, but it cannot come in here because we've already signed to a 5-year plan, and this is how it's going to run. Thank you.
Okay, thank you for that clarification, ma. Yes, let's have this. Okay, go there, then the next one will come. Since it's close to the lady.
Good evening, all. I'm Iwa Memunat from Kwara State. I'm the MIA officer for ANRiN. I want to recommend the need for a fast-track integration of data between the community-based and facility-based service delivery points. The integration of data between the community-based service delivery points and the facility delivery points, so that the data between them will be harmonized.
Okay.
I don't know if you understand me, ma'am.
You mean community-based services, data from community-based services should be integrated with that of facility-based? I thought that's what's supposed to happen. Is that not what has been happening? Okay, fine. Okay, fine. Okay, which of the community-based services? All the community-based services? Okay, okay. Thank you, madam, for that recommendation. You want to speak? Okay.
I wanted to ask her to clarify, is it on ANRiN? They have data from the community. Have they started, the NSS, have they started? So when they start, is the plan that they will not, their data will not come to the facility? Okay, the data will go, my belief, you want to add something, please add, but I'm looking at the way we do for immunization. That catchment area belongs to, everybody within that catchment area. So any information within that community goes through the facility down to the LGA. And that way we are looking at the whole population. The population of the community is not different from the population that comes to the facility. So I believe, even for the chief's agent, their data, in addition, goes into the LGA data and goes onwards. DHIS, yes, we're all reporting through that
data. Okay,
Right,
yes.
Thank you very much.
We will soon round up.
All right, my name is Musa Abubakar. I'm the M&E Cabinet State. Actually, mine is the issue of bridging the gaps, because a lot of state that has been presented, there is a wide issues, a huge gap. The government has to be committed, and in the state, unlike my state, I'm not talking about my state, but other states, the government should put more effort and mobilize more resources in seeing how to improve the nutritional sensitive activities. Thank you very much.
Oh, only nutrition sensitive activities? Don't be partial. If you do only nutrition sensitive without nutrition specific, then you are not doing effective programming. So I think it should be both nutrition sensitive and nutrition specific. Thank you. That's a wonderful recommendation. I was wondering when we are going to get that type of recommendation out of this conference. And on that note, I'm sure there's no more comment. What we are going to do is that we are going to work on this communique, because the time is fast spent, and we send to all those participants, both online and physical. They look at the communique, we give you within a week. You look at it, make your input in it, and revert back to us, the person that sent it. so that we now finalize the communique. Please, so that we have an effective communique that is buy-in by all of us. On this note, I would like to say thank you for participating effectively in this communication, in this communique drafting moment. And I would also like to call on my director, very dynamic, and also very resourceful and committed. She was chairing, flogging us up and down to make sure we come for meetings, to make sure that this is successful. I would like to say, Ma, thank you for your leadership. And I will now call on her to give us the vote of thanks to close this workshop.
Okay, before she does, we just want to quickly announce to you, for those of you who still have your air ticket, what is it called, with you, you need to submit them to her immediately. If you think you want to have your full package for coming and going to this meeting. Air tickets, please. The jackets, please submit them to her. Thank you.
Thank you, MC. Day is fast spent, so we need to run with this. Thank you. So the Honorable Minister of Health, the Permanent Secretary, Federal Ministry of Health, the Director of Family Health Department, Executive Director, National Primary Healthcare Domain Agency, the World Bank, other partners, the Honorable Commissioners of Health, Honorable Executive Secretaries for the Primary Healthcare Boards, the ANRiN, focal persons, all the participants, of course, the MC and everyone. Permit me to stand on existing protocols. I want to make the vote of thanks by the ANRiN LOC, and both Binyariam and myself are the chairpersons. So for this, I'm making this vote of thanks on behalf of all of us of the LOC and myself and Binyariam. She's not here, but I will make this for all of us, if you permit me. It's a well-known fact that there exists a close relationship between overall development of a nation and adequate nutrition. One supports the other. The expansion of nutrition intervention ought to be carried out in an organized manner so that the desired results could be effectively achieved. The scope and nature of the organized manner are essentially catalyzed by appropriate strategies such as the learning platform, the results conference. The main purpose of the conference is to exchange knowledge and best practices which could help the ANRiN project find its path for expansion. As you all know, the organization of this conference is a result of a close cooperation among several institutions and individuals. It is my great pleasure, our great pleasure, to express on behalf of the Federal Ministry of Health, the National Primary Healthcare Domain Agency, the World Bank, and of course, on my own behalf, a deep appreciation for the support and encouragement provided by such individuals and institutions. This event is a collaborative effort, a joint venture, mainly of 3 institutions. They are, in no particular order, the Federal Ministry of Health. We are highly appreciative of the leadership, encouragement, and extensive support provided by the ministry, especially the Honorable Ministers of Health, Dr. Osage Ehanire, and of course, the Honorable Minister of State, and the Permanent Secretary and Director of Family Health, Dr. Salma Ibrahim Anas. I'll also want to appreciate the World Bank. We express our thanks to the World Bank team led by Dr. Rigak Tiligiado for the unwavering technical support and coordination throughout the planning and implementation phases of this conference. You work tirelessly to ensure that technical contents for the conference are of high standards. Your coordination with the LOC strengthened our partnership with most of the international organizations that featured in this conference. The sleepless nights your team had for the success of the conference cannot go unnoticed. Without your timely and insightful advice and support, would have done very little. We know that going forth now, you will sleep much better for the next few days. For us at MPACC, our thanks due to the management of the National Primary Healthcare, led by our Visionary Executive Director, Chief Executive Dr. Feza Shuaibu. We are grateful for your support and your encouragement. We indeed are grateful to our special guests, the Honorable Commissioners of Health of the 12 states, ably represented by the Honorable Commissioner for Nasarawa State, Pharmacist Yahaya Ahmed, for the commitment and support to the ANRiN project in the various states. We appreciate your participation at this conference despite your very busy schedule. We owe a great debt of gratitude to our speakers, our panelists at this conference. When planning a conference such as this, it is imperative to gain the participation of experts in the field. Your willingness to share your time and expertise and experiences in RBF for improved nutrition service delivery in Nigeria was critical to the success of this conference. We are fortunate to have a wide range of speakers from all arenas. University of Nigeria and Nsukka gave us Professor Obinna Onwujekwe. We also had the International Medical Corps. We had Action Against Hunger, the World Food Program, Nutrition International, DRC World Bank Project, Oxford Policy Management, Dr. Belel Dome, Federal Ministry of Health, MPACDA. We acknowledge with gratitude the time, the resources, and experiences you shared with us. This is of great value to the project. The mothers and children of this country will be most grateful. It is our collective efforts and thoughts on best practice that will bring us closer to resolving World Bank, the Federal Ministry of Budget and National Planning, Federal Ministry of FMWASD, Federal Ministry of Agriculture and Natural Resources, State Ministries of Health, State Primary Health Care Board, UNICEF, HKI, NI, CHI, BA, WHO, IHP, EU, Dangote Foundation, BMGF, Nigerian Governors Forum, Pathfinder International, Affinet USAID, IHP, Plan International, FCDO, CSSON, NEMCHIC MPACDA, Damaris Care Network, University of Calabar, Federal Ministry of Oye Ekiti, ABU Zarian, and other individuals too numerous to mention who joined us in this conference. The conference was not meant to be a single event, but the starting point for the work that must be done to mitigate this problem of malnutrition once and for all. Once again, on behalf of the LOC members, of course, Binyerem and myself, we want to thank you very much for your participation, most especially for your patience and indulging us to let us go through this. Even for those who are fasting, we appreciate you. And for that which you have asked of the Almighty, may He grant it may He grant what you have asked of Him as you also commit to fasting. So it is very important that once again, I thank you for your participation at this very important conference. Thank you. God bless you. God bless the Federal Republic of Nigeria. There is some award for some people. Sorry, I forgot that. It was an award. And as part of a performance base, we are supposed to give awards. And we did agree that we'll make awards, sorry, for.
And so every one of you, I say.
Have I not said? Let me finish. Okay, so. Okay, she sent a mail saying her own thank you, which I have already done. She had just sent a mail, she's not here. So she's also saying thank you to you people. We have award for certain things we agreed as LOC. As part of the things we do, we should recognize the efforts of some people. And it's not that we have not recognized the efforts of every other person, but want to single out certain personalities from the state for one thing or the other, either through the video they sent or when they sent their presentation, or in the course of this event, how they participated. Cletus, do I have it? I know that for us, or your state takes the award for their video. Let's please applaud them and appreciate them. As the best presenter, we want to also, we're recognizing Abia State presenter. Okay, that's Oyo for the best video. What's the next one? Active participation. We also recognize, is that Kwara State? The Kwara State person? What they'll say it's all women. Don't we have any man? We want to recognize Abubakar, M&E, Nasarawa State. We also appreciate you for, oh, that's the man now, for your active participation. Who else? Gombe. Yes, we recognize Gombe also for your active participation. This goes to our state primary care, ANRiN. She was the first person that sent in her presentation. We had no problem, so let's appreciate her. Cyprian Obonna for his online participation. We recognize Cyprian Obonna SNO. We also recognize, who is this one? We've already done that, haven't we? Kwara State. But it gives me joy once again to recognize my young brothers within the LOC. And we, the LOC, we did agree that these young people did a lot and contributed a lot to this. So they are going with the Dr. Onwo's award. I want to recognize my right hand in the office. Very dynamic, very innovative. Always Cletus this, Cletus that. Please, let's give him a warm round of applause. Thank you, Cletus, for being who you are. Continue to work. We appreciate your wife for all the times we keep you late, for all the times we call you at midnight, you still pick the call. We thank you. My other young brother, Zubair, working with too many women, it was tired. But what we appreciate pharmacist Zubair, as you see him here, he is not well, but he's been dragging himself and ensuring that he will produce. Please let us also do that. So both of them go off with my award. Of course, that does not mean that other members of the LOC deserve this award, but we single this out just to show that we appreciate them for the work they do. Thank you, and thank you once again.
Thank you so much. I think she deserves a wonderful applause. Thank you for working so tirelessly also. You've been wonderful. She has been, on behalf of National Primary Health Care and Federal Ministry of Health, she has given us a wonderful vote of thanks here. However, her co-chair also, the chair of the LOC, sent a message down, and she said, to every one of you, so every one of you, I say that, I quote, I say a big thank you for making this event successful, and I wish you all safe journey to your homes. Stay safe and keep working for the optimal nutrition of all Nigerians, particularly the voiceless ones. God bless you all. That's a message from the chairman, LOC.
Dr. Binyere Ukari. Thank you. And with that, we want to say thank you all. Stay safe, safe journey back home. Lunch is
Give me. You presented fighting from the beginning. So, they